Most professionals don't lose authority
you struggle to speak up in meetings?
Good morning to everyone. We would like to welcome everybody to the very first inaugural meeting of the Crohn's Colitis Foundation India, CCFI, Tamil Nadu chapter. We have a really tight schedule and an academic feast planned in a very short period of time today. So just some general rules of the house. We request everybody to keep their cell phones on silent mode, and we request the speakers to strictly stick to the time. We have a 15-minute allotted time per speaker, followed by 5 minutes of discussion, which we can take maybe at the end of each session based on the talk. Without any further delay, I'd like to request Dr. K.R. Palaniswamy sir to come and address the meeting. And he is the convener for the CCFI of Tamil Nadu chapter. Please.
Good morning. I would like to welcome you all for this important occasion. That is inauguration of the Tamil Nadu chapter CCFI India. So I would like to thank CCFI India and the office bearers, the president, Dr. Ajay Kumar, who was the past president of Indian Society of Gastroenterology, and also the secretary, Dr. Vineet Ahuja. He is a doyen in the field of inflammatory bowel disease, and the vice president, Dr. Vandana, for having given the opportunity to sort of to run this Tamil Nadu, to start inaugurate this Tamil Nadu chapter of CCFI and take it forward in the state of Tamil Nadu. So without any further delay, I would like to request the MC to start the proceedings.
Good morning, dear colleagues. It's a wonderful day. We have planned a good academic session. So to start with, first session will be on IBD Indian perspective. I would like to invite Chairperson Professor K. Rahuram, Professor Jayanti, Dr. Ganesh, Dr. Basumani, this session will be on IBD and Indian perspective. We have two speakers. Yes.
Good morning to one and all. So we start with the first session. May I invite Dr. Ajay Kumar, President, Colitis Crohn's Foundation of India, Chairman and HOD, BLK Max Institute of Digestive and Liver Disease, to come over and make his presentation on current status and future predictions of burden of IBD in India. Over to you, sir.
Thank you, chairpersons, and thanks Palni and Amit for this wonderful opportunity to be here back again. And it's a matter of great pleasure to have the launching of the state chapter of CCF India. I think this will go a long, long way, looking at the enthusiasm of the entire team. The topic assigned to me to talk about burden of IBD in India, what is the current status and the future predictions. The first question comes, why should we study this? Why is it important to look into this burden of the disease? Well, to plan any healthcare infrastructure, the facilities, anywhere in the state or the country at a broader level, you need to know which way the disease is going to, what projections are. And accordingly, you need to train the workforce right from the nurses to the lab people to the clinicians for the early diagnosis and to have which is a very important part. And that's where these associations, societies play an important role. and then to allocate diagnostics and therapeutics for what is required for the future, as we will see in a short while, that the way the disease is increasing, the burden of the disease will increase, so you need to pre-plan for that, especially with the more newer drugs coming in, newer diagnostic modalities coming in. You need to have the right algorithms and right treatments available to the population. And of course, to understand the disease drivers for the future planning, that what is causing the change in the epidemiology, what is driving it, because so can you use some preventive things and which you can help in sustaining that. So let's look at the global perspective. Now this is something which is that they say the first case of Crohn's in Morgan 1769, but actually first description of UC colitis in 1865, almost a decade before our first war of independence. And of course, Ayurveda mentions Granny Rog, whether it's the same disease or not, we'll need to keep that here. So if you look at the history, Wilkes introduces ulcerative colitis into the medical vernacular right in 1875. And the first paper on regional ileitis came in 1932. So the gap of almost 50 years between the first UC and the first Crohn's reporting. And that's an important thing. And this is the paper that we have talked about, the Crohn's, which whenever I look at the picture of Crohn's, it reminds me of Professor P.L. Vai, who's a cardiologist at PGI, the so resemblance. But then there are 14 cases reported. Crohn's had contributed only 2 cases out of those 14. His name came as a first disease came there because he was the first author, number one, and because it was put in alphabetical order. And then secondly, because of the easiest of things to say, the disease was named after him. But since 1932, since on that, then we saw the change in the world over, that the incidence was rising. Initially, ulcerative colitis was much more common. Then the Crohn's disease incidence started rising. And then from the simple Crohn's, it became a complex Crohn's. And now it's a global disease with increasing prevalence. Now that's what is the pattern which has followed. That is how it has evoluted in the West. It's very important for us to look into that because that's how we understand that probably the same evolution is taking place in our country. So initially, UC was more than CD, then increased in the Crohn's, then increased in complicated Crohn's, and after a gap of 40 years, almost both are almost the same place. So when we look at the epidemiology of India, so what is the core concept? We were all came up with in the environment that infectious diseases rule the roost. And then if you look at the change, the transition, this is an important paper in 2017. This is basically a ratio of the communicable and non-communicable diseases, that this ratio is declining and the non-communicable diseases are increasing in India. And that is the story of the journey of IBD in India. I borrowed this slide from Ajit Sood, and it is shown that, of course, we all have been part of this history, that when we were students of gastroenterology and as a fellow, we hardly, if we ever diagnose a Crohn's, my boss will throw me out of the rounds. That's how you think of this diagnosis. And now, if you don't think of make a diagnosis of Crohn's, then it is the other way around. And earlier, without any discussion, there used to be just a tuberculosis, it's not Crohn's. And things have changed, transitional change. And see, this is a historical photo which I got from Vineet, that 1964, first seminar on ulcerative colitis was conducted at PGI Chandigarh under the leadership of Professor P.N. Chutani and Professor Sehgal, and of course you can see Professor Aikut and Professor Banerjee, pathologists over there. And then Indo-US Symposium, first one in 2007 in All India Institute. So as the awareness is gone, then the CCF was formed, and now we are into a stage where it's an accepted thing. So Professor Balakrishnan was quoted in Indian Journal of Gastroenterology in 2007. He was the first DM fellow from PGI Chandigarh, first year. He said that diseases change fashion, and the most talked about diseases those days were amoebiasis, tropical sprue, NCPF, peptic ulcer, and the newly emerging ulcerative colitis. Now, just a historical perspective. So, epidemiological transition has been from infectious to the immune diseases, which probably driven by urbanization and lifestyle. India is in the transition phase, and IBD is emerging as a major non-communicable disease. Now, coming to the specific question which was given to me, the current burden, if you look at the prevalence in Asia is high, though the incidence is less, was considered to be less, because once the disease occurs, it stays forever. So the prevalence will keep on increasing with time, and that depends upon the population. And if this is another important paper, which just I'll highlight that this is the IBD disease burden in 2010, combined with combination of ulcerative colitis and Crohn's. And if you compare with the US and Europe, and you can see that this is a big problem in our country. And estimates based on available data predict a 4-fold increase in the prevalence of IBD in India, and it's 1.6-fold rise in the prevalence of IBD in high-income Asia Pacific and South Asia regions by 2035. So by 2035, the projected growth of IBD is so high that we need to be prepared for that. So the trends of IBD in India, which I talked about, the similar slide I showed, that the same epidemiological pattern that disease has followed in the West is being seen in India. And we are actually, Crohn's disease first started being reported from the southern of India, and we always at north, we always used to consider that it's not touching us, but I think it is very much there, and I can't compare the prevalence, comparative prevalence, but we see it now as often as anywhere else. And this is our, so if you look at the Omran's graph, this is that the 4 phases in the epidemiological: emergence, acceleration in incidence, compounding prevalence, and then prevalence equilibrium. While the Western world is coming to the stage of the prevalence equilibrium, in India, and we are reaching to this area, the compounding prevalence, so we have to be ready for the future. It is going to be the biggest non-communicable disease. The epidemiological transition occurs when a country undergoes the process of transitioning from developing nation to developed nation status, and probably it's related with that, and we are looked at. And that's what Vineet wrote a wonderful review, the Great Shift East, and that's where it's exactly happening. So whenever we talk about the epidemiology, we start looking at why it is rising. I mean, the reasons need to be understood. We all know that IBD is the result of an aberrant immune response to a dysbiotic gut housed in a genetically susceptible host. To say that genetics, environment, and immune dysregulation, it's an interplay of that. And if you look at the current world scenario, that you have a peace-loving people, or you have a warmongering all over, the entire world is worried about that. So the Indian example of a controlled aggression versus uncontrolled aggression, what is going on, is and the gut is considered to be always in a controlled immunological state, fighting state, and that's what I call it has to be a controlled aggression. What factors are leading into uncontrolled that need to be studied. So the key drivers of a genetic susceptibility, urbanization, The last paper from Rupa from AIG Hyderabad has shown that even in the rural population, the disease prevalence is almost the same as in urban population. But urbanization, when I say that, the habits of urbanization, consumption of the food, the pre-packaged foods, or ultra-processed foods, all those things are affecting the microbiome changes. And of course, the exposure to antibiotics, even our PPIs, or so many drugs and other environmental factors, all is no time to go through everything in this particular short time here. But if I look at the whole thing, I like to sum it up in one sentence, that westernization is not necessarily modernization. We need to look at the right things and adopt that. So the healthcare challenges are many. And so what is anticipated, we have already talked about, that the increasing prevalence, we are going to face the problems. We need to keep calm and do what is required. And what is required is a healthcare planning of human resources and infrastructure, education. I'm actually coming to the same points which I raised right in the beginning, that it is important to study the epidemiology. Health education of diet, avoid unprocessed foods. It is becoming one of the most important issues in the gut health today. Lifestyle, avoid misuse of drugs, and of course, right focus on the legislative front and to convey upon the decision makers and for the society like CCF, then we have to maintain the registries, collect and collate data, and then from that will emerge national management guidelines, and we have to make lawmakers aware of that. So friends, I conclude by saying that India is entering into the epidemic phase of inflammatory bowel disease, large and growing disease burden, and there is a need for urgent system preparedness, and there is an opportunity for early intervention. Thank you very much.
Thank you, Dr. Ajay. Could you join us on the stage, please?
Thank you very much, Dr. Ajay Kumar, for the excellent review. This takes my memory back to 1971, when I was appearing for an MD exam. If I consider a diagnosis of ulcerative colitis, I'll be failed, right? When I'm entering the DM in 1974, if I entertain the diagnosis of Crohn's, I'll be failed. Then Professor Antia gave a lecture, oration in Bombay, 1974. Crohn's came to India, but never brought the Crohn's to India. And in those days, in our pathology book, we used to read it as regional enteritis, Crohn's. I hope you people remember. Regional enteritis, Sir William Boyd. That means only in the terminal ileum it will be affected, not any other parts. Pipe-like rigidity, that was the pathology. But now, see the leaps and bounds, it has increased. So, excellent talk, Dr. Ajay Kumar. Now I request, B.S. Ramakrishnan needs no introduction. You want to needs no introduction to this audience. And we always say diarrhea man, right? He is going to talk to us burden of IBD in India, current status and future projections. Professor B.S. Ramakrishnan.
Thank you, Chairpersons. Thanks to CCFI for asking me to speak on the goals of treatment in IBD. I think without further ado, we'll just move into the topic. So when I was practicing in Australia 40 years ago, we were told, treat the patient, do not treat endoscopic changes in Crohn's disease. So when the patient became less symptomatic, we would stop treatment. So the initial goals of treatment in IBD were, one is induction of remission. All of you of my generation will know this, that you know that drugs induce remission, and then you need to maintain that remission and prevent relapses. So induction of remission and maintenance of remission were the main goals of treatment. And of course, as a corollary to that, prevent complications. Then came the biologics. And when the biologics came, and primarily propelled by Rutgers in Belgium, the concept of mucosal healing took place. And he really tried to push it. And so that became very, very fashionable. So that became the next goal of treatment. And then came patient-reported outcome measures, which is obviously very important. And considering that the CCF is primarily a patient support and advocacy organization, that we should really look at patient-reported outcome measures. And so then the focus shifted to improving the quality of life. So what I'm trying to say is that eventually the pendulum is swinging back, and one thing that we know that we cannot achieve is cure. There is absolutely no chance that, well, I wouldn't say there's absolutely no chance, it does happen sometimes, very rarely, but patients with IBD do not get cured. So when we define remission in IBD, so these are things that I use in my practice. So when I give a diagnosis, I will say ulcerative colitis in clinical remission, or it may be biochemical remission, or endoscopic remission, or histologic remission. So clinical is absence of symptoms and signs of the disease. Biochemical remission, as you know, it is normal hematology and clinical chemistry, normal inflammatory parameters including ESR, CRP, and calprotectin. Endoscopic remission is when the endoscopy is normal. Of course, it's easy to define for ulcerative colitis, not so easy to define for Crohn's disease. And histologic remission with normal crypts and an absence of inflammatory infiltrate, and that you can define only for ulcerative colitis at present. At present, we cannot define histologic remission in Crohn's disease. But there are many goals, many goals beyond remission. So one is to prevent complications, stricture, fistula, malignancy. The second is to look at and to address metabolic issues like metabolic bone disease and anemia, which a majority of our patients suffer from, which impacts their quality of life and which unfortunately does not always get the attention it deserves. With children, there are a huge number of issues. There's the primary one is growth retardation. There is nutrition, and there are the major psychological issues because they have to fare well in school. There are many issues that they have with that. And several of these children that have IBD tend to be extremely competitive in nature. And so they have, Dr. Malati used to say they have type A personalities when she used to refer pediatric IBD many, many years ago. So these are issues in children. Social issues is something that we need to address, and I think the CCF is something that should really get into this. So financial issues, which are a major problem, job security, because have leave of absence. Very often I have to give a certificate saying, please allow this patient to work from home. Because they have to keep going to the toilet so frequently that you need to give them formal permission to do that. So these are issues that we need to take up. And then there are the issues in young adults. Both men and women come and ask, can I get married? And that's an issue. So I think we really need to tell them, yes, you need to inform the other party that that you have a disease which is the thing is likely to require treatment, and you don't know it's going to go up and down. And then with women in particular, there's issues of childbearing. So just very briefly, so here are these children. So you'll see the two siblings on the left here. So one is highly stunted compared to his brother, and then on the other side, one is highly stunted compared to his younger sister. So growth is a major issue. It obviously depends on our being able to control inflammation, although very often these people go to an endocrinologist and look for that. Now, inflammation adversely affects pregnancy outcomes. We know that if you have active inflammation, the fetal outcome is bad, and active IBD increases the risk of adverse outcomes. So any young lady who has got married and has IBD, we have to make sure that a disease, she needs to be informed about this, about conception, how to prepare for conception. And there's a whole lot of issues around pregnancy and IBD. That, in particular, what I see is that many obstetricians recommend that the patient should stop medication before they get pregnant. And they feel that, and that's something which, again, we need advocacy. CCFI, again, can do this patient advocacy and to doctor advocacy, in fact. And we need to bring out pamphlets. In fact, I take printouts from the Western hospitals, which actually have these guidelines there, and send them to the obstetrician. So this whole thing, in terms of goals of IBD therapy, the International Organization for Inflammatory Bowel Disease, basically they started this thing called Stride 1 and Stride 2, selecting therapeutic targets in IBD. The long-term targets are clinical and endoscopic remission and prevention of disability, restoring quality of life, normal growth in children. The short-term targets are symptomatic relief and normalization of serum and fecal markers. Just like we said, clinical, biochemical, and then there are the other issues. And what are not yet targets are transmural healing in Crohn's disease and histologic healing in UC are not formal targets. So this is why it's called the targets, because the center target is where you change the bullseye is where you change the course of the disease, cure. That is something I don't know whether we'll achieve in our lifetimes. So the Stride 2, the treat to target is like this. Again, it's the same thing, short-term, intermediate, and long-term targets that I talked about. Now, a lot of people that I see have actually been to this, and they are told that, you take biologics for a year, you'll become all right. And that is clearly not true. I think that's something that we should stop telling patients, that you'll be all right with a year or two of biologics. It doesn't happen. So just a little bit of information from an analysis of our IBD patients, of our azathioprine-treated IBD patients that we published a few years ago. So in this, 472 patients followed for 6 months to 20 years. Nearly 1/5 of patients were poorly compliant, and they continued to have intermittent relapses. Of the patients that were compliant, about 70% were in clinical remission, about 50% were in biochemical remission. And treatment could be stopped in very rare patients with ulcerative colitis. And there were a few patients with Crohn's disease who spontaneously stopped treatment. Obviously, they do get recurrences again and again. And these are all part of the issues that we deal with when we see patients. So in summary, what I wanted to say was that physicians and patients have different perceptions of treatment goals in IBD. Now, the Crohn's and Colitis Foundation in America is largely a patient advocacy organization funded by philanthropists who themselves or their families, like Eli Broad, they have Crohn's disease. And the main focus is really on patient advocacy. So absence of symptoms, acceptable quality of life, and limiting the treatment cost are the most important goals for patients. And I think as responsible physicians, we should understand this and treat our patients accordingly. Mucosal healing and deep remission are difficult concepts for patients to understand. You tell them they don't understand what the hell it is. And I think the other thing to remember is that cure is not possible for the majority of patients with IBD. And with that, I'll stop. Thank you.
Do we have time for discussion? Yes. Please tell us. So it was a wonderful lecture, sir. And you put it in a nutshell as to how to approach a patient with IBD. One cannot have a standard prescription for all patients. I think it has to be individualized, and then with the availability of biologicals now, it's freely available in India. I think we need to choose what type of patients you need to put them in biologicals. All of them may not require actually. So mild cases can be managed with a conservative management, but those with severe cases, I think you need to probably decide how to start, how long to give, and what you need to tell the patients as to regular follow-up and all that. The top-down is more appropriate for very severe cases, and step-up is still, I think, useful for patients who are still having a very mild disease.
So I have one question for the person. Sir, in the resource build-up, any role for IBD nurses? Do you have any vision for specialist nurses in IBD?
Definitely yes, especially with so many infusions coming up, and you need a stomach care infusions and so on. All these things, I think the nurses have to be trained. Not only nurses, the dietitians have to be trained, because a big role of diet in IBD. So when we talk about the health infrastructure and health personnel training, I think this is all a part of that. And CCF India has taken steps in that. They published a book on the, I think Vandana is here, she's published a book on the diet in IBD, and Vineet has gone ahead and now constituted the committees to have the groups to publish, frame and publish the guidelines on the different aspects, and diet is one of the most important. And secondly, what Rama mentioned about the pregnancy and child health, again another group working on the same thing. I think all these things are very important and they need to be pursued.
Medical insurance, sir?
Well, I am not the right person to comment on that. Maybe somebody else can take that. Medical insurance, how they will react and how will they take care of the expensive. We presume that if somebody has a good insurance, that will be adhered to by the insurance companies. But I know that there are a lot of fallacies in the system. Maybe VG will like to.
VGM.
Yeah, those are wonderful talks, both of them. And I just should congratulate the CCF, because even a decade back, even in a tier 2 city like Coimbatore, we had nurses training, IBD nurses training done by the CCF. So we've been very active society, and thanks to all of you who are here. So my observation and a question, like Crohn's disease, in my practice, I feel that the phenotype is changing from a simple B1 to B2, B3. Now we see more cases. Is it because of a referral bias, or is it truly changing phenotypic pattern of Crohn's in India?
First thing is, I reconfirm what you are observing, that in our practice also we see the same, that number one, that I talked about, that the Crohn's is increasing. Number two, the complex Crohn's is increasing, and the phenotype is definitely changing. But if you look at the Western epidemiological data, the same thing it went through. And that's where we say that it's a challenge for the epidemiologists to work on that, what is working. Probably we have lost that time advantage that we had to study that and to devise the strategy for the future. I think that's what is required. Of course, see, when we started seeing ulcerative colitis, everybody used to say, well, it existed, but we never diagnosed it. Now we have started looking for it. And when ulcerative colitis reached the peak and then Crohn's came, same thing, yes, it also existed, but we were missing it, we started looking for it. I think that it's a combination of, when the disease is increasing, more awareness is there, we pick more cases. But that does not mean that the epidemiology is not changed. It is so obviously there is a change in the epidemiology. And I certainly, I am the firm opinion that yes, the disease is increasing, complexity is increasing. Of course, we are diagnosing more than before in addition to that because of the, that we are more aware of it. That's this thing. Maybe Rama will add more wisdom to that.
There's one comment I want to make. Regarding the insurance, I think the insurance companies are supporting now, even for the biologicals. Some of my patients are supported by the insurance.
Thank you, sir. Vinit.
Thank you for an excellent start, 2 great lectures. Regarding the epidemiology, I think Dr. Sood and Amit have recently finished a study which has not been published. So Amit is out here. I think that's a very nice study in terms of it throws good light on what we are discussing. So Amit, if you can tell us the results of your study, it will be very enlightening.
So I think we've done a community-based study, I think Ludhiana and CMC. So gone into the community, looked at what is the prevalence. So because Crohn's we had data, UC we had data, but Crohn's we didn't have data before. So we found, we looked at around 20,000 plus patients in South India and similar number in the North India. And we found about 4 patients, 5. So the data is still getting sort of analyzed, and we will come to a number. There is a bit of a difference between North and South, but we'll now have some figures for Crohn's as well as for colitis with the difference in North and South. So I think the final thing is still sort of going to combine the data.
Like what I was talking to Ashdeep, and they presented this data in IOIBD meeting in Portugal recently. So the sense I was getting is that we thought that Crohn's is much more common in South India compared to ulcerative colitis, and obviously in North India ulcerative colitis is commoner compared to Crohn's disease. But this data shows that Crohn's is still less than ulcerative colitis.
So it's almost what I would say, sir, that in North, UC is probably more than Crohn's. In South, the difference is not, but Crohn's is not the dominant one basically, but it may be equal to a little bit. But I think in the North data, what Ashdeep picked up, they had more number of UC is what I was seeing. But it's not that in South we are not seeing more Crohn's than UC, but maybe a disparity may be less compared to what it is in North India.
I think the UC data what we have has increased substantially from the past UC data which is published. And the second thing was that Crohn's, though initially we thought it was not there, it is rising and it is a significant number, although South still remains predominant for Crohn's disease.
I've seen there is a sea change happening in the epidemiology, the phenotype also. And in down south, as Dr. Vineet said, Crohn's is increasing in. And we see less often now ulcerative colitis, number one. And there is another phenotype I've seen. Those people have software engineer gone abroad for a while and come back with the Crohn's. So we need to focus on those phenotype, why they are occurring in this kind of. I don't know whether it's an experience with the other teachers. And Ramas, your point about very nice. I think we should not aim at only the symptomatic cure. I think we should go up to the histological remission. So how aggressive you need to be to get the histological remission? In your practice, how much you could achieve that?
I just, before Rama takes, I just add one more point, that we see more Crohn's and we see more complex Crohn's. And third thing that I like to add, that we are seeing probably more young Crohn's in younger people. Now the onset disease is also younger.
So I think the feeling that Crohn's is more common here comes from, say, larger institutions that practice IBD treatment. And that's because patients with Crohn's get referred for treatment. Now, if you actually look at it in the community, ulcerative colitis is easy to treat. Basically, you give them mesalamine, and that's what most people do. I'm sure Dr. Ganesh here, when he was in DDHD, would have seen that UC was the major part of IBD which they saw. So I'm actually convinced that your data is right, that UC still remains more common than Crohn's in the community. But what we see coming to us, because they are referred to us because they just don't get better elsewhere. And maybe we'll just get a comment from Dr. Ganesh.
I think what Sir said is right. I think Crohn's gets referred to higher centers because they've already gone to 2-3 centers without any relief. I think that's how you pick up Crohn's, and that the center-biased senses are different from what is generally seen in the population. Generally, most of us sees more ulcerative colitis because it's easy to diagnose, and then you put them on treatment, they get better. And most of the patients whom we treat or we see are just moderate type ulcerative colitis. So Crohn's disease we pick up, but then when they get referred, directly Crohn's picking up in a general setup is probably much far less than when you do it in centers. But then dealing with pediatrics is different. I think the goals are different. Dr. Malati, you have any input?
I think Dr. Ramakrishna has given the goal. Our goals are a little different. Quality of life, yes, but the growth is something which is completely a different entity for us. So we have to be careful when we give steroids. And then other things, they don't like it. Compliance is worse. And at the time of adolescence, delay in sexual maturity, school problems. So little different, but otherwise we are also seeing the other trait. I think someone will be talking about it. The monogenic forms us quite a good number in the very early onset. So less than 6 years of age, if any of you see, I think we have to do the genetic studies, not wait for the conventional treatment not responding.
Thank you.
Thank you. I think we had a very fruitful discussion. I thank both the speakers for their wonderful exposition. Thank you.
Thank you. Thank you to the speakers as well as the chairpersons. We'd like to move on to the next session. The next session is on IBD therapeutics. And for the same, I would request to invite the chairpersons on stage. I'd like to call upon Dr. T.S. Chandrasekhar, Dr. Malati Satyashekaran, and Dr. K. Prem Kumar. I would request the chairpersons to take the questions at the end of both the sessions. We can first finish off with both the talks. I would request the chairpersons to please introduce the speaker. Thank you.
So we've come to the second session, an interesting part of our today's meet, and I would like to call Dr. Philip Smith, consultant gastroenterologist, Royal Liverpool Hospital, UK, editor-in-chief, Frontline Gastroenterology, and he will be speaking about positioning advanced medical therapy for Crohn's disease, and I'm sure it's going to be very interesting. Dr. Philip Smith, please. I think it's a recorded message, so we will listen to us from.
Dear colleagues, thank you very much for inviting me to talk about positioning of advanced medical therapy for Crohn's disease at your Colitis and Crohn's Foundation of India meeting today. It's a pleasure to speak to you again, and I hope many of you who I met on my fairly recent trip to Vellore remember me, and I wish you all very well. So this is a really interesting topic to be talking about, and something that is of a big conversation here in Liverpool and across the UK. Over the next 15 minutes, I'm going to talk about the aims of treatment in moderate to severe Crohn's disease, factors determining positioning of therapies, the general treatment principles we apply based upon the available literature we have in this area at the moment, guidance that has recently come out in the last few years from the BSG, British Society of Gastroenterology, the European Crohn's and Colitis Organization, and also the American Gastroenterology Association. We're going to also look at studies that have helped determine positioning or potential positioning in Crohn's disease, talk briefly about disease location-based treatments, and also what I would suggest from my own experience based upon the available literature regarding positioning. So as many of you will be aware, I'm sure treatment targets in Crohn's, but also ulcerative colitis, I know we're talking about Crohn's today, has really evolved over the last 10 to 15 years, and it's no longer the case that we see a patient and expect that just because symptomatically they may have improved on a treatment, that is the end of our target of what we're aiming for the patient. We're very much aiming for normalization of not just their symptoms, but also their biochemical markers such as their CRP, a decrease in their calprotectin to normal levels. In children, expecting normal growth and development. And we're now going as far as looking at endoscopic healing. We need normalization of quality of life and absence of disability. And in Crohn's, the ultimate aim that we're aiming for, certainly over the as a long-term target, is transmural healing. In ulcerative colitis, it's more related to histological healing. So we're getting our targets more and more ambitious over a period of time. And that is because we know that when we treat very closely, we treat patients very closely with Crohn's disease, we can actually prevent the long-term damage that occurs in this condition. We all know that over time, untreated inflammation, certainly in the small bowel, but also the large bowel, can lead to stricture formation, abscesses and fistulas, ultimately surgery, and then the cycle can continue again with intermittent flares over that time. And what we really should be doing is changing the trajectory of this disease, tied to monitoring and control of patients, so that when they initially flare, we really do flatten the curve. We really do treat them early, aggressively, and monitor it, so that if there are any potential blips in their calprotectin or in their symptom-wise, we're treating that very rapidly and effectively early on, so we don't get these long-term progressive symptoms leading to surgery and disability. So ultimately what we're trying to do is, metaphorically of course, putting the fire out, putting the inflammation out, reducing it down to as little inflammation as we can. And we know this is really useful. We know from studies that have been published that if you normalize the fecal calprotectin within 12 months of diagnosis, that is associated with the reduced risk of progression of their Crohn's disease. And you can see that here, looking at the purple line at the top, that once you get the fecal calprotectin to below 50 even, you can see that the survival remains a lot higher over a longer period of time without complications. And the approach in the UK has changed because of that. But it's also changed from this pyramid structure that we used to use where patients almost had to earn their right up to receiving biological agents. And so we no longer approach things from a pyramid-based system where they have to go on 5 ASAs before they go on to steroids, and then if they go on steroids, then they'll only be allowed to go into immunomodulators and so on and so forth, what we call the step-up approach. But very much now, certainly based upon the profile study results, which many of you will have seen published in the Lancet Gastroenterology and Hepatology, have showed that if you use top-down therapy, so your aggressive therapy, so infliximab early on, you can then get their complication, their steroid use, their surgery-free remission to a very low level and get them in endoscopic remission as well. And you can hopefully see that from the charts that are attached here. So we're using this top-down approach early on, aggressive treatment early in patients. And all of this, of course, has been helped by the fact that over a long period of time, but certainly since I would say the early 2000s, development and therapies have really accumulated, and we've got a large armamentarium of different therapies available, both for UC but also for Crohn's disease, as you can see here. But a big question about when we're talking about positioning is, well, how do we do it, and what different approaches are available? Well, there is always the argument about whether you balance the efficacy versus the safety of in terms of giving a patient a treatment. For instance, we know that steroids are really very efficacious medications, treatments. We know they induce remission, but long term they can cause major side effects and problems. And so that's why their safety risk is the highest over a period of time. We know anti-TNFs, certainly in certain populations, can be problematic as well, but they're very, very efficacious as well. And we know that the IL-23p19 inhibitors, there's 3 of them that are available in the UK, risankizumab, guselkumab, and mirikizumab. All of these medications have a fairly good safety profile and also are efficacious as well. So they're a very vogue treatment at the moment in the UK, and a very popular treatment, as well as medications like vedolizumab, which has historically had a very good safety profile, albeit not as good as efficacy potentially in Crohn's as the P19s, for instance. And of course, don't forget things like diet, very safe, but also evidence that that diet works extremely well. And then, of course, you've got the other medications historically that we've used, such as thiopurines, which have been efficacious over the years, but we know that their profile in terms of safety has got question marks next to it, certainly in the long-term use. And we know that choosing the right treatment for patients with Crohn's disease can be difficult. It's sometimes based upon their disease severity, activity, location, their phenotype, including whether they've got perianal disease, whether they've got extraintestinal disease, other associated conditions, whether they've got comorbidities such as cardiovascular disease, diabetes, infectious diseases, malignancies. And of course, you don't forget previous treatment successes or failures. I've talked about safety already, but the need for potentially combination therapies such as anti-TNFs and immunomodulators. And of course, holistically, we should be looking at patient goals and preferences, the way that they want to receive treatment, their social history and what their family situation is, whether they're planning on getting pregnant, for example, in female patients. And the general principles we apply in the UK and Liverpool is that we're trying to start effective treatment early in the vast majority of patients at diagnosis, using our best treatment first. We're trying to look at what our most effective therapies, and we think we should start thinking holistically about that. Of course, access issues and the cost may determine this as well, and that's certainly the case in our National Health Service as well. We do use a treat to target approach, so we monitor and act upon results early. So if there is a fecal calprotectin that's going upwards, we act upon that, and we don't try and stick with therapies that aren't working. We do try and work out when it's best to optimize therapies such as anti-TNFs with either increasing frequency or dose volumes, quantities, etc., versus switching. Often that can be quite difficult to understand initially, but we try and do that as quickly as possible, certainly given we have other therapies available. We know that active disease is more dangerous than any other drugs, and we know that that's been shown by the profile study. In the step-up group, they had worse outcomes than the top-down group. We know that there are meta-analyses that show that harms from placebo in RCTs are significant. We do try and avoid steroids if at all possible, although we do give budesonide in mild to moderate ileal Crohn's. And of course, we now have JAK inhibitors also available, which are helpful. We remember that surgery may be very good in isolated terminal ileal disease. It may be even better based upon the LYRIC trial, according Dan anti-TNFs, and nutritional therapy is important. And we recognize that we are changing the natural history of Crohn's disease. It's not easy, but it is possible. But we know that certain phenotypes, such as perianal disease, are a bit more difficult to treat. What guidelines are available? Now, I'm not going to have time to go through huge details of this, but the BSG IBD guidelines produced in 2025 used a grade approach. It used a network meta-analysis to look at different therapeutics across the board and updated a very detailed 2019 BSG guidelines. So as part of the grading system, it graded the evidence, meta-analysis results, the relative risk of bias, the certainty of each grade outcome was measured, as well as the magnitude of effect side. And then the grading of the evidence led to grading of the recommendations. With high certainty of evidence, meaning that we're very confident that the true effect of that treatment lies close to that of the estimate of the effect. Magnitude of effect has been published. You'll see the reference below here, but we did measure the magnitude of effect from of treatments from large all the way down to trivial. And so there was as part of the system, there was a systematic review, formulated questions, identified outcomes, then rated the importance. We synthesized the evidence, including meta-analysis and magnitude of effect. We summarized those findings according to whether evidence was high, moderate, low, or very low certainty of evidence. And then that fed into the grading of the recommendations, which could be strongly against or strongly for, and then if in between, if it's weak, we call that conditional, either against or for. So you can recommend against, recommend for, suggest against, or suggest for in terms of the outcomes. So a strong recommendation is that the desirable effects of adherence to a recommendation outweighs the undesirable effects, and conditional recommendation basically is that the desirable effects of adherence to a recommendation probably outweigh the undesirable effects, but it's not confident, i.e. potentially that could change over time. So what did the Crohn's disease assessment of advanced therapies show in the BSG guidelines? Well, it showed that all of the recommendations were conditional recommendation from infliximab all the way through to upadacitinib. And so all of those treatments are recommended for treatment in the use of Crohn's disease patients. Vedolizumab in the BSG guidelines was not, and that's because of the trivial magnitude of effect that was found when the network meta-analysis was performed. It's very important with the BSG guidelines to also know that we did not rank, and so therefore we did not position or sequence treatments. Okay, and that means that we weren't able to say you should use this treatment first, this treatment second. But as you'll be aware, there are head-to-head trials all the way from Seaview all the way to Galaxy 1, as well as the latter Galaxy studies, which I'm briefly going to show you now, which are helping us to distinguish between certain therapies, as you'll have seen on the screen here. So, for instance, the Seaview trial showed that ustekinumab may have a similar efficacy to adalimumab monotherapy in moderate to severe Crohn's disease. We showed in the sequenced study, which was published in the New England Journal of Medicine in 2004, that risankizumab, one of our new IL-23 P19 inhibitors, is superior to ustekinumab in achieving clinical and endoscopic outcomes in moderate to severe Crohn's disease. And this has really led the way and opened the door for these P19s that block that P19 subunit of IL-23 specifically, as opposed to ustekinumab, which blocks the P40 unit, which is also present on IL-12 as well as IL-23. It's led to the use of IL-23 P19 inhibitors to be widespread across the UK now. And this is a nice summary of that in a paper in Frontline Gastroenterology. As you'll have seen from my earlier slide, there are trials, head-to-head trials, which have helped us work out what treatments are better or certainly not inferior to other trials. So the VIVID-1 trial showed that mirikizumab is non-inferior to ustekinumab in achieving clinical remission at week 52 in moderate to severe Crohn's disease. But interestingly, it didn't show it was superior either. So this was one of the lesser helpful trials. But the Galaxy trials have been helpful, and we know that guselkumab is superior to ustekinumab in achieving clinical remission and endoscopic response at week 48 in moderate to severe Crohn's disease. So that's superior, not non-inferior. Other guidance, we've got the ECHO guidelines, which were published in 2004 in Journal of Crohn's and Colitis, have used a similar methodology to the BSG one. And they've summarized this, you can see on the screen here. And as you can hopefully see here, they have recommended the likes of infliximab across the board in induction, maintenance, perianal disease, extraintestinal manifestation, across the board in patients with Crohn's disease, whereas other therapies haven't met that criterion. They haven't sequenced and they haven't said this is the position of various therapies, but the Americans have. They've been slightly more brave with the summaries, possibly because this was only published at the end of 2025 last year. And so they have said in advanced therapy naive patients, the first line therapies with high efficacy medications, they're saying infliximab, adalimumab, Vedo, ustekinumab, as well as the P19, so your higher efficacy medication compared to lower efficacy medications such as upadacitinib. And then it goes on to talk about prior exposure to a more advanced therapies and which therapy you should use higher efficacy versus lower efficacy medication in, particularly if they're anti-TNF exposed in the past. There is also, from the Americans, and it has been quite helpful, some limited data for efficacy of advanced therapies in achieving remission by disease location in moderate to severe Crohn's disease, with the greater benefit of all advanced therapies, as you can see here, looking at the odd ratios in patients with colonic disease versus ileal disease. Echo in terms of oral presentations at various conferences over the last 2 years have actually talked about what they would do in various situations. Experts have talked about this, and so they've said that with moderate disease, without perianal disease, you know, the likes of anti-TNF monotherapy, IL-23 inhibitors, as well as ustekinumab, maybe your first line, but in more severe disease, anti-TNF therapies with immunomodulators such as azathioprine, a first line, followed by your IL-23s, followed by your JAK inhibitors, and if they've got perianal disease, that'll be anti-TNF, immunomodulators, and antibiotics. And then you can see what the suggestions with extraintestinal manifestations. That's where the IL-23s come in, back into it, as well as the JAK inhibitors. So my advice, what I would suggest, you can split things up into severe disease size, adverse risk disease size. If you're worried about people having serious prior infections, malignancies, maybe your first line agent should be your IL-23, and they should be positioned first, or your IL-12, IL-23 inhibitors such as ustekinumab or vedolizumab. And this is based upon the guidance that's available in the literature that's available. And then second line agent, depending on the particular patient's circumstances, and again, you need to look holistically, think about infliximab versus adalimumab monotherapy. If more severe disease, so structural damage, they've got perianal disease, significant impact on quality of life, and so on, I think anti-TNFs are difficult to beat still, and that's what the literature is showing, followed by your IL-12, IL-23 inhibitors. But I would go with your P19s, your risankizumab, your guselkumab first, as before your ustekinumab. And then your second line agents, if you've not used these already, your P19 inhibitors, followed by your IL-12, IL-23 inhibitors. Then upadacitinib, it's got a higher risk profile with likes of herpes, DVT, cardiovascular risk potentially, even though it's a more selective JAK inhibitors, but it's very good for UC, and it's good for colonic Crohn's disease as well. So that would be my advice. So effectively, early effective treatment is crucial. No treatment, i.e. active disease that's untreated, has a much higher risk to patients than no treatment, provided that treatment's appropriate, of course. You must monitor as much as you can and use a treat to target approach to flatten that curve as much as you can. I know it's difficult in circumstances, patients living far away, etc. Know when to switch. There's no point in sticking with anti-TNFs if they've got huge antibodies, secondary loss of response to it. So know when to optimize, when to switch. Evidence-based positioning is not easy. There are many factors that determine that. Individual patient characteristics, which I went through before. Steroids do work, and often we do have to use that in some of our highest risk patients as well. I'm not saying that we don't, but it does have the highest risk profile for all therapies. What we ultimately need is more head-to-head trials, but we know that they're expensive to do, and often they're governed by the pharmaceutical industry because of funding and money behind it. Final plug, please do submit to Frontline Gastroenterology. We've had great success in the Tamil Nadu region. Excellent liver paper was published in FG and actually won something called the FG Cup recently, a social media competition. And so it's a very popular patient that's been well read in FG. So do publish more with us. Very happy to be contacted. Sorry I've ran slightly over. It's a big topic, but thank you very much for listening.
We were told that this is a video lecture, so we'll not have a question. Maybe that will be taken along with it, Professor Vinita Gujja. Before moving to the second lecture, I have a great pleasure that we all should be very happy and proud having created a Tamil Nadu chapter of CCF. And I must congratulate Dr. Professor KRP giving the right direction. We give a big round of applause for that. I'm a hardcore endoscopist, and I started developing interest in IBD also for two reasons. Some of the new molecules really attracted the scientific basis, which one of them is the JAK inhibitors, Professor Vineet Ahuja. Number two reason is, every day the first thing I see a very thick file of Crohn's disease. So I need to understand so much about that. And basically it involves so much of physiology, pathophysiology and pharmacology. And the kind of relief you get from the patients you look at, that is very gratifying as the cholangitis patient removing a stone. So that are two reasons why I got interest in IBD. And maybe the one of the reasons why so much of gathering on Sunday morning. And now inviting Professor Vineet Ahuja. I know him, he's a good friend of mine. And we must congratulate him for his wonderful pioneering initiative. He has done it, and he is the professor of gastroenterology from All India Institute of Medical from New Delhi. I think it's a pleasure always watching Vineet Ahuja, and because of the review of literature he has come with it, and his own pioneering work added to that. And what is the role of JAK inhibitors? Now from the tongue twisting names, actually we all should get trained in front of the mirror. All the names of the biologicals and the JAK inhibitor. From there, it has come to stay as a stable treatment in most of the severe ulcerative colitis. Over to you, Dr. Vineet.
Okay. Thank you, sir. Good morning, everyone. Congratulations to Dr. Palaniswamy and Amit and everybody for the CCFI chapter of Tamil Nadu. And now it's what I would say, it's a lazy Sunday morning. On a lazy Sunday morning, you're allowed to have a few random thoughts. So this is a kind of thought which came to me, like the IBD landscape, it seems to be becoming truly global. I was not able to decide why this thought was coming to me, like in the sense that in radiology rounds, we were looking at the MRIs and we were looking at the contours. And one of us said that these contours look very familiar, getting a deja vu kind of feeling. Then suddenly it struck us, oh my God, these contours seem to be somewhat very similar to a picture which has been flashing to us over the last 4 weeks. And if you look at it, it's not only the contour, it is the anatomy, the geopolitical strait, the anatomical rectosigmoid, both of them choke areas, both of them very important. And yet at the same time, if inflammation strikes out here, it can be hell. Inflammation out here or inflammation out there. And clearly, for both sides of inflammation, you require urgent solutions. That is the lazy random thought came to me. But then we realized that as ibidologists, we do have some ways by which we can manage inflammation in the strategic areas. So I thought maybe I could recommend Dr. Palaniswamy and Dr. Chandrasekhar. Maybe they can invite Professor Trump for the next CCFI meeting so that he can take a leaf out of how we devise innovative solutions for managing inflammation in very strategic areas. So that is the first message for the day. Now the second thing is that I've divided my talk in some very standard, you see, housekeeping kind of evidence-based thing, that how do you manage JAK inhibitors in ulcerative colitis, what do you do? And then, since it's wartime, there are a lot of negotiable issues. I'm going to take you through a lot of negotiable issues, which I feel is important because out here I see people who are dealing with a lot of advanced IBD. JAK inhibitors, tofacitinib, upadacitinib, poor man's biological, but I would name it more as Gen Z steroid. Absolutely Gen Z steroid, because you see, like steroids, they block multiple cytokines. Biologicals are only blocking one cytokine. Tofacitinib, upadacitinib can block plethora of cytokines. They are so popular, no doubt, because no regular visits to hospital required, no injections, they are cheap, they are effective, and they are very fast acting. If you look at this slide, just read the first line out, there's nothing more than that. And that first line tells you that upadacitinib in ulcerative colitis reduces symptoms as early as day 1 of induction therapy. What can be faster than that for the patient as well as the physician? We often talk about why is upadacitinib effective in Crohn's and tofa is not effective in Crohn's. Is upadacitinib, which is a JAK1 inhibitor, better than tofa? This simple diagram, Venn diagram, explains the whole story very simply. Tofacitinib is a pan-JAK inhibitor, blocks JAK1, JAK2, JAK3, type 2. Upadacitinib is a JAK1 inhibitor. Filgotinib is also a JAK1 inhibitor. Look at the Venn diagram. You find that most of the cytokines are covered by JAK1. The cytokines which are not covered by JAK1 and are there covered by JAK2 blockade are probably the good cytokines. There are things like erythropoietin, thrombopoietin, and leptin and growth hormone, etc. So this probably throws some light on why upadacitinib may be more effective, why upadacitinib is effective more in Crohn's disease as well as ulcerative colitis, unlike tofacitinib. And it also tells you that the story of JAK is not over. It is a selective jackpot, and you find that number of agents are soon going to come up in the next 2 or 3 years, so that again you will have a bouquet of choices when it comes to JAK inhibitors. So when should you start JAKs? And since my talk is restricted to ulcerative colitis, I'll talk about UC. So these are the typical standard FDA-approved indications which are steroid-dependent azathioprine non-responsive disease, steroid refractory disease, failure of first-line advanced therapy. But we are in India. We are not in USA. And here, accessibility to drug is a major, major issue. So what I would say the indications in India for starting JAK inhibitors in ulcerative colitis would be first definite indications, what I'd say, that here in any of these indications you can start, which are steroid-dependent disease, steroid refractory disease, first-line advanced therapy, failure of first-line advanced therapy as a second-line advanced therapy, acute severe ulcerative colitis if there's a steroid refractory disease, any patient with extraintestinal manifestations like arthralgias or even pyoderma gangrenosum. Probable indications, where you may again consider starting JAK inhibitors if other therapies are failed, that is pouchitis, which is failing to respond to antibiotics. The patient cannot afford biologics. ASUC as an adjunct therapy to IV steroids right from day 1. Steroid-dependent disease, where you planning to start azathioprine, as the general rule has been, but you decide, okay, instead of azathioprine, I want to start tofacitinib or upadacitinib, I would say it's a probable indication. Again, extremely important, don't go into the overdrive. Not everybody needs to be treated with JAKs. So often you see at times, it is started as first line instead of 5-ASA. Patient diagnosed with ulcerative colitis, since it is so fast, so effective, straight away the patient started on 5-ASA plus upadacitinib. No, never do that. As the next therapy after 5-ASA failure instead of steroids, try steroids once. Patient may require just 1 course of steroids and may not require any immunosuppressive medication all through the life. Why do you want to straight away give them immunosuppressive therapy? Even disease which is doing well, having a little bit of relapse, don't jump to JAK therapy out there. You may start topical therapy out here. Then there are situations where again JAKs and anti-TNF therapy are the ones only which fit the bill. That is patients with extraintestinal manifestations, and to simplify the table, significant EIMs such as uveitis, peripheral arthritis, ankylosing spondylitis, or even pyoderma gangrenosum. There, until now, we have been using anti-TNF inhibitors, but here upadacitinib or tofacitinib can be used. Ustekinumab can be used in a setting if there is psoriatic arthritis. So if you have a patient of IBD with any of these extraintestinal manifestations, then you know that you cannot use vedolizumab. You have to use either anti-TNF or you have to use JAKs out here, and in one case you can use ustekinumab. When again not to use it? Thromboembolism? No. Pregnancy? No. Patient with coronary artery disease? Patient with history of CVA? Elderly with high risk of infection is a relative contraindication. You may think twice, but again, data is emerging that you can use in elderlies also. And cirrhosis child C, no, because it is metabolized by liver. So child A and B, you may be able to use it with lower doses, but child C, no. Now, this is a graph which shows that if a patient has renal disease, patient of IBD, which of the treatments you can use, you find that you can use any of the biologics like anti-TNFs, anti-integrins, they can be used. Tofacitinib and upadacitinib, again, since it is excreted by the kidney, so you have to reduce the dose and probably not use it in end-stage renal disease, whereas biologicals like anti-TNFs, etc., you can use it. A regular housekeeping list, that is before you start any of these immunosuppressants, what would you check for? Viral markers, latent tuberculosis, generally we do MON2, as well as IGRA, as well as a HRCT chest, thromboembolism history, CAD, CVA, vaccinate for herpes zoster. It's not that you have to vaccinate and then only start JAK. If the patient has an urgency where he has to start JAKs, you can vaccinate along with that. Lipid profiles should be checked for liver function tests because any of these patients can cause hyperlipidemia. Dose for tofacitinib, everybody knows upadacitinib just came a few months back, so the dose is 45 milligram for 8 weeks in ulcerative colitis, and then step down to 30 milligrams, rarely to 15 milligrams. For Crohn's disease, the same induction dose is 45 milligram for 12 weeks, not for 8 weeks, and then you step down to 30 milligram or 15 milligram. Can be taken before or after meals. There is nothing like it has to be taken before meals. There's a grapefruit, which is now becoming more common in India. That has to be avoided. I'll tell you the reason for that. Induction period can be extended. We have talked about cirrhosis and GFR, not to be given with azathioprine. You don't need to continue azathioprine along with it or cyclosporin, and do not combine with anti-TNF inhibitors as much as possible. The reason being that there's an increased risk of infection with both these agents, and if you combine both of them, then the chances of superimposed infection may increase. So why grapefruit? So they are metabolized in the liver by CYP3/4A metabolism. So there are a lot of drug interactions. Grapefruit is just an anecdotal one. These drug interactions are much more important. That is, ketoconazole increases JAK levels. So obviously, if you're giving JAK along with that, the patient may have increased toxicity side effects. Diltiazem, clarithromycin, amitriptyline, INH, they all increase. Rifampicin reduces levels of JAKs because it is an inducer of CYP. So there's a very strong practical implication out here. You see there are two drugs which we use very commonly along with immunosuppressants, that is INH and rifampicin. So if a patient has latent tuberculosis and you want to give chemoprophylaxis, you realize that if you give INH, it will increase JAK levels. If you give rifampicin, it will decrease JAK levels. So I do not have a proper answer to that, what you would do if you were to treat a patient of latent TB. What I would say is, okay, combine both of them, add both INH and rifampicin, but I really don't know the correct answer to that. Responses with JAKs are similar to what kind of responses you get with any of the standard biologicals which you have been using. That is, clinical remission is in the range of 30%. The clinical responses are in the range of 50 to 60%. Endoscopic responses are in the range of 20 to 40%. Same. This is a kind of rule of thumb which has become for all drugs. None of the drugs individually has gone beyond 60% for a clinical response. And that is, this figure is important because when you start a patient on a drug, you need to give them a sense of how much, what is the kind of success rate they are looking at. So we have gone through some very, very standard issues. Now let's come to tricky issues. Issues which require negotiation. Issues where I require the evidence is not so strong, yet a kind of signal is there, so you can decide on a case-to-case basis. First, acute severe ulcerative colitis, how it has changed management, how these number of drugs which are there, how they have changed the paradigm totally. So first is, in patients with acute severe ulcerative colitis, frontline therapy, IV steroids, that has been the standard of care. Would you like to give IV steroids plus tofacitinib? And check for it. Straight away start tofacitinib along with IV steroids. And the genesis for this is the famous TACOS trial which came up from Dr. Sood's group, where they randomized patients of acute severe ulcerative colitis into IV steroids steroids one arm, and other arm they gave tofacitinib 10 milligram 3 times a day for 7 days, and there was a spectacular improvement, I would say, in the tune of around 20% benefit was given to the patients got when they were put on tofacitinib, suggesting yes, it's a great strategy. The only thing is that one would have one or another study more like this, and I think it will become a standard of care. Now, subsequently, after IV steroid failure, if the patient has only been on IV steroids, you have number of choices which are available today. The ones in red out here are the ones which you can't use because they'll not be effective. Maybe in anecdotal cases again, but not really. Adalimumab, vedolizumab, ustekinumab, P19 inhibitors, ozanimod, no, they will not be effective if patient has failed IV steroids and you want to use salvage therapy. Whereas infliximab, cyclosporin, tofacitinib, upadacitinib, surgery, they are all very, very viable options for all of you. So the algorithm becomes a patient has failed IV steroids. We know till now that we have been using either infliximab or cyclosporin. So comes up a third arm that you can also use JAK inhibitors, something like tofacitinib, and look at the response. And here again, the responses have been very good. So much so that since people no longer use cyclosporin much, they seem to be hesitant in using cyclosporin, that the algorithm has become something like this. Tofacitinib or upadacitinib in one arm versus infliximab if patients have failed IV steroids. I know there is no randomized control trial or a head-to-head comparison between infliximab and JAK inhibitors in this kind of setting, yet at the same time, if you look at a lot of cohort data, retrospective data, which is available for tofacitinib, you do find that 7-day responses, treatment failures, colectomy rates in this setting are equal to when you give infliximab. So if a patient has failed IV steroids, you want to decide, should I give infliximab or should I give tofacitinib or upadacitinib? You can use any one of them. There are certain soft points which can help you to decide. If a patient is biologically naive, has normal serum albumin levels, you can use any one of them. Patient has baseline hypoalbuminemia, don't use infliximab, straight away go in for JAK inhibitors. Why? Because infliximab efficacy is affected by serum albumin. Anti-TNF exposed, again, obviously the answer is very simple. You would go for JAK inhibitors. Patient has history of DVT, cardiovascular risk factor, you would go for infliximab. Another soft point if there's that if the patient has CMV colitis, probably JAK inhibitors exacerbate CMV colitis. So there you may think about using infliximab instead of JAK inhibitors. Can upadacitinib be used in ASUC like the way we are talking of tofacitinib? Do we have data for that? Yes, we have data for that, which shows that tofacitinib and upadacitinib have similar kind of efficacy in the second of acute severe ulcerative colitis, so you can actually use any one of them. Now I come to the next tricky question, which I call very, very tricky. So with your permission, I might have to take 2-3 minutes extra. My previous speakers have been very, very efficient. Maybe I can use the time they left for. So the second thing is which JAK to use first. Why? Because now I have both the agents available with me. A patient comes to me, should I use upadacitinib or should I use tofacitinib? Every time I sit down and think about it, which agent should I use? The cost is almost similar, not major difference in both the costs. Tofa is cheaper. So there seems to be good data for supporting one of the candidates. These are all retrospective studies, but again, this study shows that in patients with ulcerative colitis, steroid-free remission was much better for patients with upadacitinib compared to tofacitinib. It was higher. A network meta-analysis which shows that upadacitinib was marginally better than tofacitinib. Rapidity of action, upadacitinib 1 day, tofacitinib 3 days. Safety. Adverse events are equal with both of them, upadacitinib and tofacitinib. The serious adverse events are much more with tofacitinib compared with upadacitinib. So the verdict out here would be that UPA seems to be more efficacious, has a rapid onset of action, comparable adverse events, cost is almost comparable. So most of the times nowadays I realize that I hinge on more towards upadacitinib. That also when I remember the first Venn diagram which I showed you, that JAK1 selective and sparing JAK2, and probably that way probably the efficacy would also be more. Now if TOFA fails, do I need to change out of class? Do I straight away need to move to vedolizumab, ustekinumab, infliximab, or I can still give upadacitinib? Can I change within class? This is a very important question. Well, yes, you can. The studies have shown
that if a patient is on tofacitinib and has failed, and if you want to change over to upadacitinib, there's a good 30-40% chance that the response would be captured, and it also works the vice versa. If a patient is on upadacitinib and has failed, some of these cases also benefit by going on to tofacitinib if the patient cannot afford biological therapy. So the take-home message is that switching within JAK inhibitors is valid and practical strategies, and secondary loss of response are the patients who have the best candidates. The better outcomes obviously are the patients who have failed tofacitinib and they go on to upadacitinib. That is obviously a much more better scenario. And in upadacitinib, you only switch when there are adverse events like acne or something, which I'll talk about. What is new about JAK and pregnancy? Till now, we have been having this kind of slide that pregnancy, JAK totally out, lactation, JAK totally out. Do not think about them. Stop 4 weeks before conception. Methotrexate, yes, we know, and S1B podulators, again, we know you do not use. That has been the traditional strategy. There has been a shift which has occurred over last 6 months or 1 year. What is that shift? This is an abstract in UEGW, this thing. What I'll tell you about the abstract is this shows that there were patients, 38 patients of tofacitinib, 15 patients of upadacitinib who conceived while they were on the drug. And 70 to 80% of them continued the drug and went through the full pregnancy, and the adverse events or congenital malformations were not seen, or they were higher than the other group. In fact, the global consensus statement on management of pregnancy now is talking about it as a relative contraindication, not an absolute contraindication. And this becomes important. In fact, they talk about that if the maternal outcome is, the health outcome is very bad, then in that case, you may consider continuing JAKs even in pregnancy. I would take it with a little bit of what I would say pinch of salt, yet at the same time, it shows you the frame shift which is occurring. Otherwise, the general teaching has been a patient of JAK, you have to stop 4 months before conception. If a patient conceives while on JAK, you have to immediately stop JAK. There's a shift of winds out here. Another very important side effect you should be aware of, because you're using it more commonly and you do not appreciate, is JAK acne. JAK acne is that steroids we know cause acne, but JAKs cause much more, equal amount of acne, I would say, as compared to steroids. Steroids cause acne after 1 or 2, 3 months. JAKs can cause acne within 1 to 3 days at times. It is not dependent upon time. The acne is much more with upadacitinib as compared with tofacitinib, but the prevalence of acne can be the tune of up to 30% of the patients can have them. So the practical algorithm is inform the patient of the risk of IBD treatment associated acne. They should know. They should not come back 7, 10 days later acne, and you're also thinking that the patient is not on steroids. From where did the acne develop? Secondly, reassurance. It is a mild to moderate disease. Third, reduce the dose. If they're on higher doses, you may reduce the dose. The acne starts going up. You may have to give a drug holiday. Second, remember, JAK hepatotoxicity can occur to the tune of 3 to 5%. For example, there's a case started on upadacitinib on 1st of February, and 7 days later, the enzymes just started shooting up. They went up to more than 5 to 7 times the normal. And other all viral markers, everything was negative. The moment you stopped upadacitinib, they came back. So upadacitinib hepatotoxicity is to the tune of 3 to 5%. Appreciate that. Third, JAK can be associated with sudden onset anemia. You start a patient on JAK, and Dr. Palaniswamy would also remember a case, and immediately the hemoglobin would drop down to 8 or 7 or something. You look for markers of inflammation anywhere, you would not find any markers of increased activity or inflammation. The proper mechanisms are not known. It is not very common, but yes, it is a side effect which is appreciated and should be known about it, in the sense that you should be aware about it, and that is that it probably leads to G6PD hemolysis or something like that, which leads to a kind of hemolytic anemia, and there's a sudden drop in hemoglobin, and the best strategy is immediately stop the JAKs at that time, and the patients benefit with that. A patient with refractory UC has to be put on upadacitinib. He is refractory to all other therapies. There is no other therapy available. He has a history of thromboembolism. What are you going to do? Till now, we have been all taught that, yes, we do not use upadacitinib when a patient has thromboembolism. There are case reports, there are certain case series also which have shown that if a patient is in such a setting, if you put a patient on anticoagulants, along with that, if you give JAK inhibitors, probably you can tide over the crisis. You can give both of them, and the chances of thromboembolism would go away. The next question which comes is that a patient is on 45 milligrams of upadacitinib, has partial response at 8 weeks. Now what do I do? Should I switch therapy or should I continue with it? How long can I continue the induction therapy without the patient having serious adverse effects. Again, pivotal trials which have shown that if a patient is not responding to 8 weeks of induction therapy, either tofa or upadacitinib, you can move on to at least 16 weeks, and 50% of the patients end up capturing the response. So don't be in a hurry if the patient has a partial response, particularly if the patient cannot afford anything. You can be patient, and 50% of these patients would end up capturing the response. And at times, some of these patients which are being followed up in USA, I've seen, and also in Delhi, they are sometimes even going up to beyond 24 weeks or more than that for induction therapy, which I've seen. If the patient is on upadacitinib 30 milligram and relapses, what are you going to do? It's very simple. It's not a protein-like antibody biological, where there may be an episodic reaction or something like that. It's a simple hydrocarbon. You just hike up the dose back. You increase the dose back to 45 milligram, reinduce the patient for a few weeks. You'll be able to capture the response, and then after a certain period of time, based on a judgment, you can drop down to maintenance dose. My patient is on upadacitinib and 5-ASA, is doing well. Should I stop 5-ASA? Again, a slightly tricky issue. The evidence is not so much in favor like the way we have evidence of biologics. Infliximab, adalimumab, vedolizumab, it is very clear. You stop 5-ASA. Here, evidence is building up, but yes, evidence suggests that you may be able to stop 5-ASA. In fact, the recent Asia-Pacific guidelines, which have just been accepted, states that it may be considered in UC patients who are on JAK inhibitors doing well, you may consider stopping 5-ASA. Finally, JAK inhibitors are very important for combined advanced targeted therapy, that is combining two advanced therapies in very, very aggressive diseases. For example, of 35 patients at AIMS who are on combined advanced targeted therapies, these are the various combinations which have been used, and you find that JAK inhibitors are being used in 7 of them, and obviously they are going to increase. And then some of them who failed the first combination go on to second combination. There you realize that 3 patients are on adalimumab and upadacitinib. That is the kind of combination which we frown upon, where we feel it has to be strictly regulated because the chances of infection are very high. But at the same time, with JAK inhibitors, it's very easy to put a patient on advanced combined therapy. And the most provocative slide is out here, recent trial, which shows that we are talking of combining 2 medical therapies. Why not combine medical therapy with a surgical therapy? So these are patients of ulcerative colitis. So this is a Dutch trial. This is a Dutch trial which recently came out, where patients who were on infliximab, when they were not responding, they were randomized to either appendectomy along with infliximab, or on the left-hand side, the infliximab was stopped and they were only given JAK inhibitors, and it was seen that the patients who were given infliximab plus appendectomy, they performed much, much better. So finally, to conclude, as I told you, there are definite indications, there are probable indications, but remember when not to give. That is equally important. Do not go into the overdrive of giving JAK inhibitors to everybody. Then these are issues which require negotiation under considerations, where there is a shift of winds in terms of their changes occurring, where ASUC, yes, IV steroid failure, definitely. In aggressive cases, an adjunct to IV steroid straight away when you start it. You may think about upadacitinib, may be better than tofacitinib. If one JAK fails, you can give the other one. Adverse effects, some effects you should remember, one tends to overlook them: acne, hepatotoxicity, anemia. JAK and pregnancy is becoming a relative contraindication. JAK and thromboembolism, acceptable if you give anticoagulants. If there's a partial response with induction, you can prolong the induction period. Can I stop 5-ASA? Yes, and dual therapy in refractory cases. Thank you so much for your attention.
Thank you, Professor Vineet. Excellent, exhaustive exposition on JAK, and rightly highlighted the side effects. So you mentioned clearly JAK is not a joke if you don't understand the side effects. Thank you. And Prem will handle the...
Any questions? Such a lucid exposition as usual, sir. My question is on appendectomy. How does it help ameliorating IBD?
So this was a trial which looked at appendectomy plus medical therapy. Prior to this, the trials have come out which have only done appendectomy in patients with mild to moderate ulcerative colitis and shown the benefit. The probable reason why it is effective is that appendix is a lymphoid organ out there. So initial trigger for the immune cells may be out there. So the supposed mechanism is that if you remove that initial trigger from there, that may lead that the whole cascade of events may not occur. One. Second proposed mechanism is that since cecum is also a reservoir for a lot of bacteria out there, so it may lead on to beneficial bacterial effect that is there. So we do not have a very clear-cut reasoning, but these are the suggested mechanisms.
And they say the post-appendectomy Crohn's is on the rise.
That's on the other hand. The appendectomy has been protective for ulcerative colitis, but it has been thought to make the disease of Crohn's disease more aggressive. That is because in Crohn's disease is a terminal ileal disease. That is a Paneth cell disease. So probably out there the terminal ileal changes, they are more important. At AIMS we recently did a thesis where there were around 8 cases where they underwent appendectomy for mild ulcerative colitis, and 6 out of those 8 cases seem to be doing well. They're doing well for 1 year.
Sir, 2 things, sir.
It's a low-cost option.
With regard to liver toxicity, like ATT, we have more than 3 times symptomatic, more than 5 times asymptomatic. Is there any limit where we have to stop or come down on the dose of Upada?
So there is no defined limit, but the frequency is different. For 3 times upper limit, the frequency would be of the tune of 5 to 10%. For more than 5 times upper limit, the frequency would be the tune of 1 to 3%. Even hyperbilirubinemia may occur out there. So the question is, should you stop at when it is more than 3 times, or should you stop at more than 5 times? We do not know. It is a question of judgment. If the patient continues to have rise in the enzymes, then you have to stop, because the enzymes can go beyond 5, more than 10 times in these cases, and can be protracted for weeks.
Second thing is with regard to dyslipidemia that happens in these patients on Upada. They are young people without any other comorbidities. How to address the dyslipidemia?
So dyslipidemia I did not cover because that's a very common adverse event. So dyslipidemia occurs, it's a transient dyslipidemia. It can again out here the moment you so you have to do a lipid profile after 4 to 6 weeks after starting. At 3 months definitely it has to be done. If you find dyslipidemia, best is to add statins along with that, and because the therapy is more important, so you add statins, and for all you know, statins may also be exerting their anti-inflammatory effect.
Thank you, sir.
Comprehensive talk. I enjoyed. There are only just 2 questions. What is the incidence of ulcerative colitis in post-appendectomy patients? Are there any study?
So there are
Will it prevent ulcerative colitis?
So initial epidemiological data showed that patients who had appendectomy, they had less chances of developing ulcerative colitis. I won't be remembering the exact figures, but the conclusion would be this: less chances of developing ulcerative colitis. And secondly, if patients had ulcerative colitis, their disease course would be much milder compared to patients who had appendix in situ.
I have experience with bovine colostrum in a good dose is rewarding in patients who are refractory to almost all the drugs. They have been posted for surgery. They came to us. I have at least 4 or 5 patients. More useful in pediatric patients. Adult patient, he has gained weight at least 5 to 6 kilos in 2 months' time. Totally asymptomatic. Repeat after 3 months of therapy showed almost excellent endo results. Biopsy, of course, minimal.
Yes, sir.
I
Sir,
await more studies
sir,
in India.
please
to
brief,
take it up.
so I think we'll start the inauguration. Just quick.
Sir, you treat adult patient also, sir?
I do treat, sir.
So this kind of.
Yes, the last.
No, I'm just in the
just
lighter sense.
last question from me. This regarding the drop in hemoglobin. I discussed with you earlier also. One of my dermatology colleagues, he was using. He was telling me he starts with a lower dose and monitors the. He also had the similar experience of drop in hemoglobin. The other problem which I faced is a respiratory failure in one patient. Even literature says that patients with a compromised lung, there's a possibility they can go in for this respiratory issues. Your comments, please.
So we haven't come across any respiratory adverse event as yet with JAKs, but yes, you would be right, sir, in the sense that they can be there. But anemia, we are coming across cases, and it is kind of initially very puzzling that why do these patients drop so much of hemoglobin? You think there's an ulcer out there or something, but the patients do not have so much of endoscopic activity.
I think we have been told the last question himself said. I think I must congratulate once again Dr. Vineet Aguja, Philip Smith for this wonderful lecture, along with my co-chairs Dr. Malati and Dr. Prem. I just want to tell you, when you're beginning of practice, you have to know thoroughly about the tongue twisting names. You practice. I'm just telling in the lighter sense to conclude. I softly mentioned Tofa. He had it as sofa. So how sofa will help, sir, and all. Then the Upada, I said, he did not hear properly, and he said Yanada. So I think what I just want to tell you, all these medicines as blessings, and Upada has come in place of biological, so he rightly highlighted, and we have more questions to discuss in coffee break. Thank you very much for this.
You're inviting President Trump for the next meeting?
Thank you so much, sir. Thank you to all the chairpersons. We'd like to move to the inaugural ceremony. For the same, I'd like to call upon Dr. Amit Datta, who is the co-convener of the CCFI Tamil Nadu chapter.
So good morning, and thank you all for coming for this inaugural event for CCFI TN chapter. So to begin, I'll call the office bearers of CCFI, the national office bearers, Dr. Ajay, Dr. Vineet, and Dr. Vandana on the stage. And the CCFI Tamil Nadu chapter office bearers, Dr. Palniswamy, Dr. Piram, Dr. LVK, Dr. Alagamai, Dr. Rajesh, Dr. Kandaswamy. So all of you, please come on the stage. Yeah. Everybody is here, no? I think. AJ, where is AJ? AJ is here. AJ is. AJ. No, sir. It should be all right. We can get some. Okay. I think we'll, if everybody is here, yeah. Enough number of chairs, no? So again, thank you all for sparing your time. I think so. We'll start with the lamp lighting ceremony, followed by felicitations. So can we have the lamp lighting by all the dignitaries on the stage, please? Yeah. Yeah. So we'll start with the felicitations of the national office bearers. Again, I must thank them for taking the time off and coming and being with us at this important occasion. So I'll ask Dr. Palniswamy to felicitate Dr. Ajay Kumar, who is the president of CCFI national body. Can I request Dr. Rama to felicitate Dr. Vinit Ahuja, please? Okay, I request Dr. Venkat Krishnan to felicitate Dr. Vandana Midha, please. Okay. So now okay, thank you. So I think we'll begin with Dr. Palniswamy sir giving a welcome address to the gathering. Sir.
Good morning. I'm very happy to see you all on a Sunday morning as the hall is fully packed. I would like to thank the office bearers of the CCFI India for having given us this opportunity, especially the President, Dr. Ajay Kumar, Vice President, Dr. Vandana, and the Secretary, Dr. Vinit Ahuja. When Dr. Amit and Dr. Paramanagam spoke to me that we should organize, that we should probably that's the inaugural meeting and inauguration of this CCFI. So we thought that it was the right decision, and we should, because the problem of IBD is on the increase, diagnosis and management also is complex, and we need to address this issue, not only in academic forums, also the public awareness, the patient support systems, all these things are very important. Of course, we have been doing a lot of programs in Tamil Nadu under the banner of Tamil Nadu Gastroenterology Trust and also the Tamil Nadu chapter ISG. Many programs we have done. We have had this international program on IBD in 2017. Vinith was part of this, he was in the faculty. Also later in 2023 also we had a national meeting on IBD where international participation online, where again Dr. Vinith, Amit, everybody, they are all here. Apart from the scientific meetings, we have held several the patient interaction programs. That is all our, we have just called our IBD as Crohn's and even UC patients. We have had a discussion with them, and the patients also participated actively. So that really gave a great confidence in facing the problem. Also in those meetings we discussed about the support systems, how to support the needy patients. I think that probably we need to hold more meetings and address the government also, the CM scheme. So it's being they support the cardiac patients, cancer patients. Similarly, I think probably we should aim to achieve support for the IBD patients also. Even during COVID time, we had the online, the meetings, patient interaction programs, which also went on very well. So once again, probably I think with this inauguration of this CCFI Tamil Nadu chapter, we should take forward all of these issues, and that we should benefit our patients. Thank you very much.
Thank you, sir, for the welcome address. So I think I'll just give a brief 2 minutes overview of what TNIC state chapter sort of is about and what is our goals. So first of all, anyway, thanks to the national body, Dr. Vinit, Dr. Ajay, Dr. Vanna, and other team members for giving us this opportunity to form the Tamil Nadu state chapter. And we have a wonderful team, as you can see on the stage, led by Dr. Palniswamy. And so basically, like any other thing, we have three main objectives. One is for the patient care, second is for the education, and third is for the research activity. And in the previous online meeting of the governing body which we had, we discussed a lot of things which we can do to improve the patient care, including patient advocacy. And like one of the things we're saying is we can even make the facilities for treatment in the government hospitals much better. We can make access to advanced therapy as it is for some other disease, like sir was saying. So there are different things we can do for the patient. For the education, we can have these periodic meetings where, like with the sort of educate the residents, the consultants, everything. And also about improving the awareness of the disease in the community. We can have some community outreach programs so that people are aware and we have early diagnosis of the condition. Also, forming a group gives us opportunity for research. We can have collaborative research. We can answer questions which are difficult to answer from a single center study. Also, we know there are regional issues in terms of disease, so that can be also addressed. So it gives us multiple opportunities, different things we can do. And I think with the support from the national body and our members, I think we'll be able to achieve our goals. So next, I think I'll request Dr. Ajay Kumar, our president of CCFI, to address this gathering. Sir.
Thank you, Amit. Well, first of all, it's a matter of great pleasure to be here for this particular occasion of a launching of a new state chapter. And Tamil Nadu, my experience as a past president of Indian Society of Gastroenterology, I can say without any inhibition that Tamil Nadu state chapter of ISG is one of the best run state chapters. So if I have to take it forward from there, what I'm hopeful is that as CCF is a much younger organization and it takes its path to create states chapters, I'm sure with the able leadership of my old friend Palni and Amit, it is going to be surely a path-breaking step and an example for the rest of the states to follow. Now see, we talk about various associations, unions and all that. When we talk about a subject-related thing or any professional-related organizations, like for that matter even ISG, STI, NSL and anything, CCF is not a trade union organization like IMA. It's a professional organization. So what is expected, what Amit rightly said, you are looking at education, you're looking at research, and 3, you're looking at the patient's interests. So a lot of these things, I think Rama, when he's presented his placement of advanced, he talked about in context of India, and he did mention at a number of places what CCF should take up and do it. And there are plenty of jobs to be done. We had talked about it, but I think 2 things which we can start with is to have a registry and to have the state-based data of all the aspects that we have discussed in the last 1.5 hours of what is more common, how is more common, and how severe the disease is, and at what age it comes. All those factors, the answers will come from that, and that will pave the way for the future interventions. And of course, education has to be there, but more important than that, as important as that, will be to have collaborative studies. In today's time, if you have to do any research, this has to be collaborative, multi-centric, and if we can start that, Tamil Nadu can set an example for the rest of the country to start some collaborative projects within the state and within the country. I'm sure it will go a long way. And with that, I wish you all the best and thank you very much.
Okay, thank you, sir, for your address. So next, I'll ask Dr. Vineet to say a few words.
It's a big honor to be here, and I would like to congratulate Dr. Palaniswamy and Amit when I see this overwhelming response out there. On a Sunday morning, when you have a hall packed people who want to come for a Colitis and Crohn's Foundation meeting. That shows there's amazing interest, and there's also outstanding leadership out here. And I think this state chapter is going to do exceedingly well. And why I have to do exceedingly well? Because I see history out here. Tamil Nadu, when it came to IBD, chronic diarrheal diseases, was always the cradle for the best of the things which came, best of the science which came out from here. Dr. Ramakrishna, Dr. Jayanti, they came out with such sterling stuff in last 2 decades that has been what I would say the harbinger of IBD research in India. Dr. Palaniswamy came up with such educational initiatives, such patient-centric initiatives, that for patients it became very easy, and also for the physicians, the awareness really increased. So already I would say the successful seeds are already there, and it would be a great chapter. And CCFI, I think, would make every effort so as to help the state chapter in making greater strides. CCFI was conceptualized by Dr. Ajit Sood, Dr. Vanda Midda, Dr. Ajay, and I think it has become a great organization. It has been recognized by the Indian Society of Gastroenterology, and so that places much greater responsibility on this organization to deliver for the gastroenterologists and also for the patients. And I think Tamil Nadu chapter is going to play a sterling role. Congratulations to all of you.
So thank you, Dr. Vineet. So I'll request Dr. Vandana to say a few words. Also about the membership, if anything is there, ma'am, how people can become members for the the CCFI.
Well, thank you very much. And first of all, I must congratulate each one of you for this launch of the Tamil Nadu chapter of CCF India. In fact, it's a privilege, and I'm very happy and proud to see the strength here, and we believe that you have actually trusted the strength of CCF and gone ahead with all this. Again, very hearty congratulations to the leadership here and to everyone here. Second thing, I hold the post of Joint Secretary. I think everybody has been mentioning it as Vice President, which is not there. And as far as membership is concerned, I would request each one of you to join in to become a member of CCF India. We would be updating the website very soon, but presently there is a site there. On the website, there is a point from where it can be done online, or you can contact any of us. And all the best and heartiest congratulations to each one of you.
So thank you, ma'am. And now, so again, as you see, we have a wonderful group of governing body members. All of them, with Dr. Palaniswamy, they have worked hard to have this inauguration thing going. We have Dr. Piram, Dr. AJ, Dr. Alagamai, Dr. Venkat Krishnan, Dr. Kandaswamy, Dr. Rajesh, Dr. Rama. So I think from them, I'll ask Dr. Rama to who's got years of experience in IBD, to say a few words to the gathering. Sir.
Thank you. I think this is a great thing that we are starting a Tamil Nadu chapter of the CCF India. So my very first encounter with a patient with Crohn's disease was when I was coming to Vellore to attend the interview to join MBBS. So my father introduced me to his colleague who had been diagnosed with Crohn's disease in CMC. This was in 1969. And he said he's got Crohn's disease, and he's being treated there, and you're going to go there. And so that's my first patient that I saw. 8 years later, when I was doing my MD, I saw my second. So this gentleman continued to, he lived till 65 or 70, and he passed away peacefully. The second patient with Crohn's disease I saw was 8 years later, when I was doing my MD. And this is a young lady from Kerala who was operated for small bowel Crohn's. She had recurrence, reoperated, recurrence, reoperated, and she ended up with short bowel disease, and she died eventually. So these are two different kind of spectrums of Crohn's disease. There's somebody with fairly benign Crohn's disease and somebody with very severe Crohn's disease. But it's been around for a long time. And subsequently, obviously, we've gone on to have major number of patients with Crohn's disease. With reference to what Dr. Ajay Kumar was saying about getting registries, so, and I think TNISG under Dr. Palaniswamy's leadership has been actually quite active in this, and then we've had multiple joint multiple collaborative ventures which have gone on, the most recent of which, as we heard Dr. Philip Smith say, won the FG Cup. And so we had our experience of IBD published in, so this is more than 1,000 patients from Tamil Nadu. That was published in JGH Open a few years ago. And I believe that we will go on to other collaborative efforts as well. I was also congratulate Dr. Palaniswamy because I know that for several years, every year he runs a program where he calls back his patients with IBD and does kind of, I think, support activities, support groups for them. So I think this venture, that the fact that we are going into this is very good. I'm all for patient advocacy. I'm all for patients' rights, and I think that we should provide them the best support that we can. Thank you.
So thank you, sir, for that wonderful address. So now we are coming almost towards the close of this thing, and before I'll call Piram for vote of thanks again, thanks to CCFI India and also the Tamil Nadu chapter of ISC Gastroenterology, the Tamil Nadu Medical Trust, who all supported in holding this meeting. I think Dr. Arul, Dr. Karthik, they have been sort of emceeing the ceremony. And again to Dr. Palaniswamy again for this guidance. And the whole thing is probably possible because of his active and enthusiastic leadership. We've been able to have a standalone. We thought initially we'll club it with a existing program, but sir said no, we should do a standalone program. It's an important topic. So thank you, sir, and Piram again, who's been tirelessly working all this while. So Piram, I'll call upon you to propose the vote of thanks. Thank you.
Good morning. It's my honorable duty to propose a vote of thanks. I think Dr. Amit has done most of the job on my behalf already, so it makes my life a lot easy. So I thank all the national faculty who have come around here, Dr. Ajay Kumar, Dr. Vineet, and Dr. Vandana, to have spared their time to come over and inaugurate the state chapter. And I also thank all my governing council members who spared their time to come around and be part of this inauguration function. And also to all the delegates and the faculty who have come around on a Sunday morning to be part of this wonderful meeting. That shows the amount of interest and the probably increasing caseload and the difficult decisions that we need to encounter in a daily practice. And I also again thank Dr. Palaniswamy and Dr. Amit Datta for taking the initiative to bring down and to start a Tamil Nadu state chapter. I think we had this discussion about two and a half months back, and we have been working on it, and it has come out very well. I thank you all and for this opportunity. Thanks. Sure.
We would subsequently be breaking for tea or coffee break. It's exactly 10 minutes. We'll start at 11:30 exactly. You can feel free to bring it inside the hall and have. Tea and coffee will be served in both the halls, one to the right and the left.
They should come back in 10 minutes time. 11:30 aa jayega.
We'll start. 11:30 start.
Dear colleagues, welcome back. So we'll go to the next session without much of a delay. This session will be on endoscopy in IBD, as well as a talk which is prepondered, navigating medical management of IBD during pregnancy. To chair this session, I would like to invite Dr. V.G. Mohan Prasad, Dr. Ubal Das, and Dr. Bala Murali. So we'll be having 3 talks in this session, and we'll have questions at the end of the session.
Well, friends, after the brief tea break, I think you're all energized now to move on. So, congratulations to Professor Dr. KRP and the entire team for putting up such a beautiful program today. And now the present session is on endoscopy in IBD. It has got 2 lectures. One is surveillance colonoscopy and detection of dysplasia in IBD, which is really tricky. As we have all been seeing, we cannot differentiate sometimes between early neoplasm from just change that happens with aging ulcerative colitis. The second part is even more intriguing and interesting, the endoscopic management of perianal fistula. To deliver the first talk, so the hero Amit Datta will be here to speak on surveillance colonoscopy, how to detect dysplasia in IBD.
So the topic which I'll be covering is surveillance colonoscopy and detection of dysplasia in IBD. So now all of us know that if somebody has a long-standing ulcerative colitis or a long-standing Crohn's colitis, there is a risk of dysplasia as well as cancer in these patients actually. So therefore, for these patients, because there is a risk of dysplasia and cancer, surveillance colonoscopy is recommended because surveillance has shown to improve survival in these patients, and normally surveillance begins after 8 to 10 years. Now, I think in my slides, there's some issues with the pictures because of compatibility issues, so please bear with me for a few pictures, but I'll take you through the slides. So in IBD, what happens is there is a background chronic inflammation in inflammatory bowel disease. And because of the background chronic inflammation, there are a lot of the genetic changes, mutations which keep happening, which keep accumulating. And this predisposes the patient to get cancer. And because of the chronic inflammation in the background, what we call as a field cancerization. So these patients tend to get more than 1 lesion. So they often have multiple areas of dysplasia. Now the one difference between cancer in IBD versus the conventional cancer is that all of us know from our sort of gastroenterology days that in the normal cancer, APC mutation happens first, but in the cancer of the colitis, APC actually happens later. Normal thing, P53 happens later, here it happens earlier because of the background thing. Histologically, there are different types of dysplasia, conventional, non-conventional, again I won't go into details, but dysplasia is one common box in which we keep all these sort of entities together. So the question is like, why are we talking about this topic? How important is this? What is the magnitude of getting colorectal cancer in somebody who has ulcerative colitis or Crohn's colitis? So here I'll present the data from Asia Pacific region. This again is a meta-analysis by Dr. Vineet Ahuja's group. And in this meta-analysis only looked at the Asian countries, and there are 3 studies from India. So there's one study from AIMS by Dr. Vineet's group, one from CMC by Dr. Rama and team, and one from Dr. Devendra Desai in Mumbai. So what these studies tell us is that in the first 10 years, the risk is about 0.02%, which is not good, not too high. But at the end of 20 years, the risk becomes 4.8%, and at the end of 30 years, it's 13.9%. In the West, it's about 18%. So there is not too much of a difference. But what you see is that in the first 10 years, the risk is not that high. And that is why the guidelines say that surveillance begins after 8 to 10 years. But beyond that, the risk jumps to 5% at 20 and about 13% at 30 years. So there is definitely a high risk of getting dysplasia and cancer in somebody with colitis, and they have to be on surveillance. So that was about the magnitude of problem. The second question is, if you do surveillance, can you change things? Does it improve the outcome? Now, it's very difficult to do a randomized trial between surveillance and no surveillance. So there are observational study data only, and whatever observation study data has shown, two main outcomes: does it reduce mortality, and what about the stage of cancer detection? And as you can see that in terms of mortality, there is about 60 to 70% reduction in mortality from colorectal cancer in patients who are undergoing surveillance. Also, you are about 5 times more likely to pick up an early stage cancer with surveillance, which can then be managed more easily than an advanced stage cancer. So definitely surveillance is helping in terms of reducing mortality as well as picking up lesions at an early stage. So we discussed about how the cancer develops, what is the actual risk, does surveillance improve the outcome. Next is, which patient should we subject to surveillance? So here again, remember, it's both ulcerative colitis and Crohn's colitis. Sometimes we don't think about Crohn's when we think about surveillance, but if somebody has a Crohn's colitis, that person also has to be in a surveillance like a patient with ulcerative colitis. And from the data I showed you, first 10 years, the risk is not very high. So surveillance begins usually after 8 to 10 years of the onset of symptoms. Now, how frequently should you do the surveillance? How frequently should we do the surveillance? So once you start the surveillance, every patient doesn't have to have the same interval between the colonoscopies. You have to do the risk profiling of the patient. And that's what different societies talk about, the ECO, BSG, ACG, etc. That after the surveillance, you risk stratify the patient based on different factors, like how severe the inflammation is, what areas, how extensive the disease, is it left-sided or a pancolitis, history of cancer in the first degree relatives, pseudopolyps, etc. So once you have these risk factors, then you can determine what interval the surveillance should happen. There are some differences between different guidelines, but essentially everybody is saying that you do a risk profile based interval screening. So after first screening, the subsequent depends on the risk profile. Two important points to note is, if somebody has primary sclerosing cholangitis, which is not that common, not as much as in the West, in those patients with PSC, the surveillance begins at the time of diagnosis. You don't wait for 10 years. If somebody has a primary sclerosing cholangitis, you start surveillance right away, because the risk of colorectal cancer is very high in this group. If somebody has a proctitis, then surveillance is not required. So now the main question about how do we do, so that was the main topic, how do we do surveillance? So we've discussed about the progression, what is the actual magnitude of problem, and does surveillance improve outcome? Yes. Which patient do surveillance? Again, after 10 years you start, and then based on the risk profile, you decide how frequently you should do. The next question is, how should we do surveillance? So traditionally, it used to be a white light endoscopy and random biopsy every 8 to 10 centimeter. But the problem with these white light endoscopy random biopsy is that often these dysplastic areas are very flat and not very easy to see, and so you may miss them. And random biopsy has a very poor yield, because each biopsy covers so you're hoping that when you take a biopsy, it may be going and hitting that dysplastic area, the chance is very little. And also people found that people who've had surveillance, after a while, some of them came back with cancer, which told you that there is a miss rate of cancer. So the standard white light endoscopy is not very good, and you need something better. This is again just showing a few studies where they looked at what is the yield of a random biopsy. So this study, first one, if you see, they took 2,700 plus biopsies, only one was a positive. So it's like a futile, too many biopsies to pick up one lesion. So currently, what is the standard of examination is you have to use high definition endo. That's a minimum. Any surveillance for colonic cancer in a colitis, you should use high definition white light endoscopy, not the standard definition, because high definition picks up about 2 to 3 times more number of lesions. Now to this high definition, you can add a chromoendoscopy, which can be a dye spray, or a digital chromoendoscopy. The most common example which is used is narrowband imaging. In dye spray, the thing is you have to spray the dye, so it's a bit more time consuming, and once you spray the dye, then you can't undo it. Whereas in digital chromoendoscopy, you can switch between the NBI and the white light mode. So some form of chromoendoscopy is required to improve your yield, but at least basic minimum high definition white light endoscopy should be there. So earlier it used to be recommended only for high definition dye spray chromoendoscopy, and then there are subsequent quite a few comparative studies which have shown that both dye spray and NBI are not significantly different. So you can use either technology. So I prefer NBI because it doesn't involve use of dye. So now what do the guidelines say? So in the earlier guidelines we're saying for surveillance it is dye spray chromoendoscopy. So now there is a big shift. If you look at the ECO 2023, the AGA and the ESG, so two main shift is, one is they're saying you can use either. You can use a virtual chromoendoscopy like NBI, or you can use dye spray. I mean, they're not saying which one is, both are same. So it's not that NBI is superior, both are same. You can use whichever you are comfortable with. And now from random biopsy, they have moved to targeted biopsy. So there's two big shift. Use either virtual or dye-based and take targeted biopsy. The only situation where you will take random biopsy is patients in high-risk group like primary sclerosing cholangitis, or if somebody had a previous dysplasia. Otherwise, high definition with some chromoendoscopy and targeted biopsy is what you should use. The recent BSG guideline, which Dr. Philip was alluding to when he made his presentation, is that they are still with the dye spray. They are still not recommending, so there are some differences, but as of now, most societies are talking about that these two modalities are similar. So you can use this thing. So the thing is, that's about detection. Now, when you see a lesion, there should be some standardized, some proper method of describing. That's very important. Like if you see a dysplasia, what are the attributes you are going to report for the dysplasia? So the ECO talks about these 5 S: site, size, shape, surface, and surrounding. So if you look at these parameters should be described in your report. So again, a separate slide for this. Site is where the lesion is. Size is what is the diameter of the lesion. The morphology, we should talk about the Paris, polypoid, sessile, or the elevated flat lesions actually. And to that, we have the scenic modifiers, which talks about the ulcer and the border. So site, size, Paris classification, how is the border, is the ulcer present or not, is there any evidence of submucosal fibrosis, and the presence of inflammation in the background mucosa. So all these parameters should be reported whenever we are reporting a dysplasia in IBD. The one limitation is that when you're doing a dye spray chromoendoscopy or a digital chromoendoscopy, you see the surface patterns. How do you interpret the patterns is a bit more of still not sort of very clear which is the best classification to use there. And the modified KUDO is appearing a bit more promising, but still it needs more work to be done. So all of you know that KUDOS has been there before NBI came into existence. KUDOS was mainly for colonic polyps. If you have type 1 and 2, hyperplastic, type 3 and 4, adenomatous, type 5 is cancer. Now this has been modified for the IBD. So the important thing is in IBD, type 1, 2, 3, 4, all of them can be dysplasia or none of them can be dysplasia. So if you have a type 1 and 2 which has this visible vessel or some heterogeneity of pits, it still says it is dysplasia. So you cannot apply the straightforward KUDOS type 1 and 2 say no. If you see the visible vessel or pit heterogeneity, dysplastic. Type 3 and 4, if there is a fibrin cap, then it is unlikely to be dysplastic. That's a subtle difference between the two, but again, these things need a bit more validation. So I'll just show you some examples of this is NBI, so digital chromoendoscopy surveillance for patient with ulcerative colitis. This is the white light image on the left-hand side. I think the arrow is not seen there. And on the right-hand side, you see the NBI image. Okay. I don't know if I can get the pointer. How to get the pointer actually? Yeah, laser pointer. Okay. So now this is the white light image. This is the NBI image. So on closer examination, you can see some dark spots here. And when you do the near focus, they just like same nice regular round pit. So there's no dysplasia. Just the blood flow is increased. So this area, even though it's darker in color, there is no change in the surface pattern. There's no dysplasia here. But this example, if you see, this is on white light. And there is this area which has got a subtle, slightly elevated lesion which you don't see in the surrounding area. This is on a high definition white light endoscopy. And when you switch to NBI, you can see the typical KUDOS 3 and 4 type of pit pattern in this area, which tells you there is a dysplasia. This is an elevated lesion which is much easier to see compared to a flat lesion. And again on NBI, you are able to see more information compared to what you get on a white light assessment. I'll just run a small video of one of our cases. How to get this video running? Oh, sorry. Can we get this video running on the thing, please? Yes, can you run this video? Okay. So this again is a patient ulcerative colitis. We are doing a surveillance with digital chromoendoscopy, NBI. So obviously we begin with the white light. So on NBI, this is the pattern you see in a normal area. You can see how the round white structures with the brown thing surrounding, which is the honeycomb pattern. This is a normal pattern. Now this is the dysplastic area we saw in the white light endoscopy. And then we switch to the narrowband imaging mode. And you can see very clearly in this area, the whole surface pattern has become very different. It's again the elongated and branched area in this particular. So this is a typical example of dysplastic lesion you see on an image. Now remember, as I told you, there is a field effect. These patients are likely to have more than one lesion. So even if you've seen one, you shouldn't be happy. You have to look at different areas. Like in this patient here, another area where there was a dysplastic focus in this particular patient. Now, the traditional, what has been recommended earlier was the dye spray, which is still the recommendation. Again, so this can also be used. And the dyes, usually methylene blue, indigo carmine, one of them can be used. And as you see, this is an example of dye spray. So on white light, the lesion is seen, but when you spray the dye with a spray catheter, the lesion becomes much more easier to visualize. So again, for those of us, whatever we are comfortable with, we can use dye spray or a narrowband, whatever we are comfortable with using. But we have to use some technique like this to make it easier to visualize the lesions. Other thing which I forgot to mention is that for surveillance, make sure the disease is in remission. If there is a lot of activity, active inflammation in that setting, it's difficult to interpret the pattern and also look for dysplasia. So as much as possible, the disease should be in remission before doing a surveillance actually. Now finally, a word about Crohn's colitis. As I was telling that when we talk of surveillance, we think about ulcerative colitis, but remember, Crohn's colitis also has a risk of cancer, and those patients should be always on surveillance. This is one of our patients with Crohn's colitis who had a stricture, which on biopsy turned out to be actually carcinoma. So just to summarize what I have said, because of chronic inflammation, these patients have a risk of getting dysplasia and cancer. The data from Asia Pacific, the meta-analysis with Dr. Vineet's group showed that at the end of 20 years, it's about 4 to 5%. At the end of 30 years, about 14% of patients have a risk of dysplasia, so it's quite a significant risk. If you do surveillance, there's a reduction in mortality. You pick up lesions at an early stage. The surveillance should start 8 to 10 years after the diagnosis. And how frequently you do surveillance depends on basically the patient's risk profile, the different factors which have been mentioned. The technology, basic minimum is a high definition white light endoscopy. The standard definition is not very good. To that high definition white light endoscopy, you can add either a digital chromoendoscopy like NBI or a dye spray like a methylene blue or indigo carmine. So thank you for your attention.
Lovely talk, Amit. Do we take questions now or at the end of both the talks? After both the talks? Yeah, after 3 talks, okay. Yeah. Oh, okay. I think Dr. Vandana will be speaking now. Okay. Yeah. So, because she has a flight to catch, and so she'll be speaking on navigating medical management of IBD during pregnancy. Professor Vandana Mida, the Joint Secretary of Colitis and Crohn's Foundation of India.
Thank you very much. So this topic has been touched by 2-3 speakers, and I would be just navigating through all this. Once we talk of management of IBD during pregnancy, it entails 2 things. One is maternal disease control as well as fetal safety. So we know that IBD definitely is increasing all over, and the diagnosis, importantly, is made in the childbearing ages in more than 50% of the patients. And about 25% or maybe more, they become pregnant after the diagnosis of IBD. So it becomes imperative to understand the co-management of IBD and pregnancy to optimize the maternal as well as the fetal outcomes. This is one common clinical scenario which we all come across. A 26-year-old female diagnosed with ulcerative colitis a few years ago reports to the OPD. She's very anxious looking, comes running. She says she has a list of questions with her. Can I conceive? Will I pass this on? Am I prepared? And are the medications safe? So all these questions are very valid. And once we talk about these questions, when the patient comes to us, first thing is heritability, which is a matter of great concern. We need to tell our patients that this is a multifactorial disease involving the genes, the environmental factors, as well as the gut microbiome, and this disease penetrance is not very strong. But nevertheless, we should tell our patients that if one parent is affected, the risk of transmission of the disease varies from 3 to 4%. And if both parents are affected, the disease may go up to 33%. And this is more prevalently seen in CD as compared to UC. But we need to tell them again that genes are not modifiable. So we need to concentrate on some of the modifiable factors which have been identified, which includes smoking, maternal smoking, both active as well as passive, which can influence the fetus, prenatal antibiotic use, which can alter the gut microbiome and can affect the infant, the Western diet again. So these are the modifiable factors which are in our hand, and genes cannot be controlled. The other important thing what comes to the patient's mind is, can I conceive? The ability to get pregnant. So women with IBD, according to the recent global consensus, it is mentioned that women with IBD, they may have reduced fertility compared to women without IBD due to reduced ovarian reserve. The anti-Mullerian hormone, which was seen to be low, significantly low in patients with IBD more than 30 years of age. But the reassuring part is a person, if the disease is quiescent, if there has been no prior surgery, the fertility rates would almost be the same. In fact, because of the anxiety and the fear, the voluntary childlessness has been said to be higher than the non-IBD patients. Some of the factors which influence the ability to get pregnant, which are age. Obviously, as age increases, fertility decreases. Any medical condition, any chronic medical condition, in this case, we are talking of IBD. And again, I mentioned disease activity. If the disease is active, fertility rates are decreased. Any history of prior pelvic surgery, any history of pouch surgery, some gynecological factors, and most importantly, the nutritional status of the patient as well as history of substance abuse. These are the factors which influence the ability to get pregnant, and we should be trying to control as many of them as possible. The referral for assisted reproductive technology, normally it is after 12 months of unsuccessful conception, but in patients with IBD, a patient should be referred for after 6 months in case a patient is not able to conceive after 6 months. And women with IBD may undergo oocyte retrieval without an increased risk of flare. So once with assisted reproductive technologies, again, there are equal chances of achieving a live birth, except if there is history of previous surgery in CD or IPA failure in UC. The other common concern is the effect of pregnancy on IBD. The disease course during pregnancy has been seen to be linked to the disease at the time, or disease activity at the time of conception. So literature suggests that if the person has quiescent disease at conception, only 1/3 of the patients would relapse. Whereas if the disease was active at the time of conception, 2/3 will have active disease, or they may continue to flare off and on. Vice versa, the effect of IBD on pregnancy, this is a meta-analysis which with 28 studies, it reveals that pooled analysis reveals that there is increased risk of preterm birth, small for gestational age, low birth weight, spontaneous abortions, and stillbirth, again, if the disease has been active at the time of conception. So all this underscores the importance of disease remission at the time of conception, and here comes the point for preconception counseling and planning. The preconception visit is obviously going to be a loaded visit. We need to optimize the disease of the patient. We need to see the disease activity, give appropriate medicines to optimize. The objective has to be medical remission. The objective remission has to be achieved prior to conception, and the ideal time which is said is at least 3 months prior to conception. We need to review the medications and see if there are any of these contraindicated drugs. Methotrexate needs to be stopped 3 months prior to conception. Apart from that, apart from disease optimization, nutritional optimization also should be one of the targets. A well-balanced diet involving all the micro and the macronutrients, with special emphasis on iron, special emphasis on folic acid needs to be given. We've discussed about the risk behaviors like tobacco and alcohol, which needs to be stopped during pregnancy and postpartum. And this is the time when we should be looking at the multidisciplinary approach to these patients and take informed decisions. Women with IBD who are desiring contraception, not willing for pregnancy, should use long-acting reversible contraception over the estrogen or a combination contraceptives. This is highly recommended, and the failure rate is less than 1%. How do we monitor disease during pregnancy? Apart from the clinical symptoms, blood workup will not be very helpful. ESR rises, CRP also rises in pregnancy. So fecal calprotectin, less than 150 microgram per gram of stool, is considered to be the best reliable method to assess the disease activity. In case we need cross-sectional imaging, bowel ultrasound and MRI without gadolinium, especially in the first trimester, are the better options as compared to single CT scan. Endoscopy during pregnancy among women with IBD is considered low risk, but should only be performed if it needs to change the management. As far as the disease, pregnancy of women with IBD is concerned, it should be always considered as high risk for complications. And we need to manage all IBD patients with active disease just as seriously and at the same lines as a non-pregnant patients. We need to start or optimize the same effective therapies as in non-pregnant, with the exception of thiopurines, methotrexates, JAK inhibitors, and CYP receptor modulators. Even if corticosteroids need to be given, we should be giving them because it is the effective inducer and it is the disease activity which is going to cause adverse outcomes rather than the drugs per se. Antibiotics, low efficacy antibiotics, low risk antibiotics should be given in patients with infections, pouchitis or perianal fistula. Venous thromboprophylaxis where indicated. Surgery should be pursued for appropriate indications in a timely manner rather than emergent. So the stress here is that the goal has to be rapid resolution of inflammation and not avoidance of effective therapy. There is mention of that patients with IBD that they are at a higher risk of preterm preeclampsia and low dose of aspirin by 12 to 16 weeks gestation to prevent preterm eclampsia is suggested. It is not a recommendation as such in the global consensus, but it is a suggestion, and one needs to be aware that it does not increase the IBD risk flare. As far as medications, which form a big chunk of the talk is, we have a lot of medications. So again, the guidance has to be afraid of active disease and not active medication. Going into various groups one by one, methotrexate, as previously mentioned, is clearly teratogenic and should be avoided. And it, in fact, has to be stopped 1 to 3 months prior to conception. But if a patient inadvertently or unknowingly gets pregnant on methotrexate, we need to get the counseling from the obstetrician, we need to involve them, get scans, because it is not an indication for immediate termination of pregnancy. We need to counsel the patients, but the only point what we can do is give folic acid as to avoid methotrexate-induced embryopathy or craniofacial abnormalities in these cases. Aminosalicylates is a low-risk drug and is safe throughout pregnancy as well as lactation, but one point we need to consider is that this is the most frequently stopped drug during pregnancy, and one should be looking into the adherence of all therapies once the patient is on follow-up visits. Again, thiopurines are considered low risk and they can be continued throughout pregnancy as well as in lactation. They do not increase the risk of any congenital anomalies or increase risk of any serious infections, but we need to be aware that there is a risk of intrahepatic cholestasis which can occur, and in those cases, liver abnormalities, if they occur, it's an FDA warning, but in case it occurs, we can either split the dose of azathioprine or maybe continue with biological monotherapy. Corticosteroids, again, it is said that it increases the risk of preterm birth, low birth weight, as well as increase in the neonatal ICU admissions, more than 2.5 times. But it is the only drug or the first-line drug which should be used for control of disease. So if you have an active flare, one should not hesitate in giving corticosteroids. As far as second-line corticosteroids are concerned, we need to look into the disease severity because it is effective and timely management of corticosteroids, which is important. And once we are giving these corticosteroids, we need to monitor the blood pressure as well as the blood sugar levels of the patients. As far as anti-TNF and other MABs are concerned, they are heavy molecules. They do not cross the placenta immediately in the first trimester, but second and the third trimester, there is a steady flow of these biologicals. But the good point is it does not increase the risk of infections. It does not increase the risk of congenital anomalies. So it is considered safe throughout. Initially, there were timings that we should give it 4 weeks earlier prior to delivery or something like that, but presently no such guidelines exist and it can be continued right in the way they are. As far as JAK inhibitors and these CYP receptor modulators are concerned, Dr. Vineet already mentioned about it. Presently, the present data is that it should be avoided. It should not be started during pregnancy. It should be avoided. But again, if inadvertently a patient becomes pregnant on these JAK inhibitors, we need to counsel. There have been 74 patients who have been unknowingly exposed to this drug, and majority of them, they usually stop in the first trimester. But what has been seen is that there is no increase of preterm birth or any low birth weight or increased risk of infections. But there is one study where it mentions that these patients, 2 of the patients out of 55 on JAK inhibitors had congenital anomalies. Again, mode of delivery, it has to be guided by the obstetric indication and as per the personal preference. Vaginal delivery is preferred and cesarean is recommended only if there is active perianal fistula. There is rectovaginal fistula, which could be active or past, and the functional IPPA to protect the sphincter. And if the patient has had a stoma during pregnancy and delivery, what needs to be monitored is displacement, the retraction, the prolapse, and enlargement owing to the changes in the abdominal wall. As far as postpartum is concerned, there is an increased risk of flare which has been reported, and it is related to the active disease either in the third trimester or a therapy de-escalation which has been done in the third trimester. Venous thromboprophylaxis, again discussed based on where indication. If a patient gets postpartum depression, patient needs to be treated with appropriate medications. As far as postpartum pain is concerned, first line therapy is acetaminophen or NSAIDs. Opiates remain the second line of therapy, and the disease seems to be controlled with, the pain seems to be controlled with IV ketorolac, which is quite commonly used. Breastfeeding, obviously the health benefits stay. It is said to be protective against the development of IBD, which is said to be dose dependent. 12 months versus 6 months has been tried. It does not increase the risk of postpartum flare, and safety data for IBD medications is strong. We do not give methotrexate, allopurinol, thalidomide, and small molecules need not be started in the postpartum period, breastfeeding period. Again, vaccination is an important thing for the children, the infants. As far as the inactive vaccines are concerned, they trigger an adequate immune response and should be given on a schedule. As far as the live vaccines are concerned, we need to look into the risk-benefit ratio, but there is data which says that rotavirus, which is a live virus, may be provided on schedule in patients who have biological exposure. But as far as BCG vaccine is concerned, we need to avoid it for the first 6 months if exposed to biologicals in utero due to sepsis and disseminated infection. So to conclude, this all management requires multidisciplinary care. The rates of fertility are almost normal. We should achieve remission before conception, and we should maintain remission during the disease, during pregnancy. Active disease needs to be is more as compared to the medication risk. The treatment, as far as treatment safety is concerned, we need to avoid methotrexate. As far as present date is concerned, we need to avoid the JAK and the SNP modulators. Mode of delivery based on obstetric indication, C-section reserved for perianal and the rectovaginal fistula. Breastfeeding is safe for most of the drugs, and we avoid live vaccines in biologically exposed infants in the first 6 to 9 months. Thank you very much.
That was a wonderful and very informative lectures. Yeah. Any questions to Dr. Vandana? I think we can raise. Who wants to go a little bit earlier?
Ma'am, good talk. I just have one doubt. You said 3 months of remission is necessary to plan the conception. In case a patient become accidentally pregnant, do you advise MTP or you allow the patient to continue the pregnancy?
We allow to continue the pregnancy. There is no formal data to identify that what is the time period preconception. So what is suggested is 3 months.
Most of the times we have a question from pregnant ladies. What is the safest drug, irrespective of whether it is UC or Crohn's disease or ulcer disease? So what's your comment on that? They ask, what is the safest medication available, since I'm in first time of pregnancy?
See, we need to convince our patients. So this requires actually counseling. We need to tell them that majority of the patients are on safe drugs, except for the mentioned drugs which I mentioned, but it needs time. And we have to tell them that they should be aware of active disease causing more complications rather than the medication being a risk in these patients.
And now there have been a lot of studies which showed that on azathioprine they don't develop any teratogenicity in the fetus. So it seems to be safe.
So nice talk, ma'am. See, this biological drugs, when you look at the product insert, sometimes they'll be very ambiguous about pregnancy safety, But the guidelines, so that's where, so sometimes I'm saying, how do you handle that? Like even vedolizumab, I don't think they're saying outright that pregnancy, but there's no safety concern. So what do we do in those settings? Yeah.
I think we need to continue with the medication. This is what has been asked for and it should be continued.
There are no more questions. Thank you so much, ma'am, for dropping in and being a part of this program. Thank you. So now we move on to the next topic, endoscopic management of perianal fistula in Crohn's disease. Professor AJ needs no introduction. And this is a really evolving topic in the endoscopy management, right from visco clips to plugs to whatnot, even plasma therapy. A lot of things are there, mesenchymal stem cells. I think we are all ears to know what is new in this field. Professor AJ.
Good morning, chairpersons and colleagues. Mine is not a very literature-based talk. Mine is just going to be the experience that we have in handling some of the patients' problems when they come to our IBD clinic. And one of them is the perianal disease. I feel it's one area that is not really discussed much. Patients also hesitate to bring it up. I think probably it is a good topic for Pan-Tamil Nadu study of how Crohn's disease affects social life of patients. Whether they stop going for functions, attending weddings, going out with friends, remembering where all the toilets are. So that's one area. I'm sure it is very different from Western kind of society where things are different. So I think Algamay will take note of that. Just the social impact of IBD. It is interesting to note that epidemiologically, perianal disease is supposed to be more common among Asians with IBD compared to Western data. I'm not sure why, but there is some suggestion towards that. And the commonest thing is perianal fistulae. It's usually associated with proctitis, so it's unusual to find isolated perianal disease. Usually there's proctitis, so one way to make sure that you're on the right track is to check the rectum and see if the inflammation in the rectum has settled down. Interestingly, if you look at the initial biological studies which looked at fistula healing rates, there is no good parameter to assess fistula healing. So the first study on infliximab, which came out about fistula healing, the healing is decided by the investigator if they press around the opening of the fistula and there is no discharge. That is described as healing. If you do an MRI, the tract always remains there. Sometimes there is a lot of inflammation, sometimes it looks more fibrotic, but the tract is always there. And once a patient goes off treatment, these fistulas tend to recur. These patients, when you see them, you will obviously have a scopy. You also need an MRI. A good pelvic MRI is your starting point. You can see what is in between the fistulae, how complex it is, because sometimes there might be only 2 openings, but in between there is an intersphincteric horseshoe abscess, or it's tracking anteriorly or posteriorly. So start with an MRI. If you want to look at the MRI images, look at the T2 weighted fat suppressed sequence. That gives you the best images of the fistula. Usually our protocol is like this. Once the patient has got a perianal fistula, we call the surgeons. Colorectal surgeons are involved. Usually it happens in an MDT, and then they will ask the patient to come for an EUA and drain out collections, put cetons, and then the patient comes back to us. Once that part is taken care of, then we are happy to immunosuppress the patient, either give steroids or azacitidine. But something that happens, at least in CMC, is that it is very difficult to get a surgical appointment on the same day. So the patient goes, maybe a week later sees the surgeons. They will post for an EUA maybe in 2 weeks' time. And the whole process just takes too long. And to worsen the situation now, we live in separate campuses now. So the colorectal surgeon is in a campus that's 15 kilometers away from the campus where gastroenterologists work. So MDTs have become Zoom meetings, and our physical MDTs don't exist anymore. So I had this patient who had the experience of going to the colorectal surgeon. Are there any surgeons in the audience? Okay. So who had the experience of going to the surgeon, but that coordination, it was not happening at least I know in my center. Maybe your center is different and you work, maybe your colorectal surgeon is sitting in the next OP room. So there was one patient who said, I can't go back to the surgeon. You do whatever you can within this department. And our IBD clinic is set up so that they don't have to go to multiple locations, and we try to sort out everything in one visit for the patient, including nutrition, diet counseling, vaccination, dermatology consultation, everything in one. So anyway, this patient was happy with that arrangement. So I'm going to take you on a small series of cases that we've done where we've been able to perform at least part of the role that the surgeon does. In your endoscopy room, I'm sure you all have EUS, and if you use your radial EUS and look at the anal canal, you can quite clearly define the sphincter. You can see tracts which are the fistula tracts which contain air. So the air artifacts you can see in the fistula tract. You can see the way it's a horseshoe fistula, intersphincteric plane. You can see it going anteriorly. And I think it's a skill that's very easy to learn because you're dealing with only about 4 or 5 centimeters of length. If you have dedicated probes, you can use that, or just your regular radial EUS scope. There are some techniques where you can augment the visualization. One of them is by injecting a little bit of hydrogen peroxide into the fistula tract, and you can see the fistula. There are other things which are described, which is 3D rendering of the tract, but we don't have that. I put it there only to say that that's also possible. Do a careful endoscopy, and sometimes the fistula can be quite low and it can be missed. Sometimes there's an associated stricture, so you might have to use a smaller scope like a pediatric scope. Here it shows a retroflex view of an internal opening. The first one showed it at the top of the anal canal. This one is in the lower rectum. Sometimes there are multiple openings. It's the same patient actually. All these 3 openings are in the same patient. Then an EUS assessment. Here This is also something you can easily do in your endoscopy room. This is a male patient, so that's a prostate. You position it at 12 o'clock. And I think it's not that clear because it's a little bright. But I don't know if you can see. Is it a pointer? Is it a pointer? Okay. Okay, anyway, it shows an EUS, radial EUS of the anal canal, and you can see the internal and external anal sphincter. And there's a subsequent image that shows you can follow the bubbles and see where the tract is. So all those white, bright shadows are the collections. So now that's in the intersphincteric plane, and you can see it tracking anteriorly and going towards the, actually this patient had, you can see it tracking anteriorly towards the root of the scrotum. So it is quite possible to, I mean, you always have the MRI, but still get a good idea of what you're doing when the patient is in endoscopy. The other thing that we have access to is lot of nice hydrophilic wires in endoscopy room. So when you have identified either the external opening or internal opening, you can pass a wire through it. And our wires are actually quite atraumatic compared to the probes that are used generally. So the patients don't require deep sedation, or conscious sedation is usually sufficient. And at the same time, it's a outpatient procedure. I don't give antibiotics for any of these patients unless there is an active abscess or there's a lot of inflammation in the perianal region. These are done as outpatient procedures and no antibiotics. And these loops, these silicon threads are called Vessi loops. They are vascular loops. These ones that I've used here are, there are two sizes. They are called thin loops, and if you talk to the surgeons, they'll tell you thin loops and thick loops. The surgeons, when they do seatant placement, they generally tend to place thick loops, but I prefer to use these thin loops because there's not much of, it's quite easy to place and the patients feel comfortable. They don't feel the loop when they're sitting and moving around. So you can use various accessories. You can just, I mean, use your imagination. You can use curved catheters, you can use curved guide wires, you can use your fluoro, you can use methylene blue to track it. Here, this picture, actually, this is when I started doing it. These are from catheters I got from cardiology. So you can use anything that will help you change directions and take a wire. Initially, I started doing this and placing these infant feeding tubes, which are small Ryle's tubes. And the problem was that they become very brittle over time because the plastic, you know how a Ryle's tube, if you leave it in for too long, it becomes stiff. So these tubes were uncomfortable for the patient and they would break. But after shifting over to these Vessi loops, it's fine. So this are two patients where we required the help of fluoro to kind of get the wire across. And this is another patient where there were two external openings. We never found the internal opening, but the wire went through one external opening and came out to the other external opening. and the patient remained well. As I mentioned, proctitis, you should look at whether proctitis is active, because that is one of the reasons why patients come back with new abscesses and fistulae. So I've tried this in about 14 patients, and I've been able to place Seton successfully in 11 patients. 3 patients I could not. There was clinical benefit, I would say, in 9 patients, and the problem is that our patients are most of the time not able to afford biologicals, and most of them are on azathioprine. And maybe with the upadacitinib, the scene will change. Maybe it's going to be more upadacitinib. But these patients, once a Seton goes if you look at when you should take out the Seton in biologicals, when you're treating a patient with biologicals, they say in about 2 weeks, 4 weeks, you can take off these Setons. But when your patient is on azathioprine, you're not really getting 100% like mucosal healing. So how long do I keep the Setons? Actually, I keep the Setons indefinitely. If they fall off and the patient says, I'm okay, I leave it. So that is currently what I've been following. 2 patients had to come back for repeat procedures, one because the disease was not controlled, and another one because I had missed one of the fistula and the drainage was not adequate. I think that's my last slide. You can manage with existing accessories. I think if you are trying to fulfill a gap or a need that the patient has, sometimes this is a good solution. The last 2 pictures actually are, one is a village which is about 25 kilometers from CMC, and the second one is Bangalore airport that I went through a couple of weeks ago. I just put those 2 pictures just to show that, you know, there are 2 Indias. It's not everybody who can afford biologicals, and it's sometimes we have to change our treatment depending on who we are talking about. Thank you.
So, thank you, Professor AJ. Could you join us on the stage? May I request Dr. Amit? Where is Amit? Please come over to the stage. We'll quickly take some questions from the audience. And can I start with the first question to Professor AJ? So, before that, I just want to know how many gastroenterologists, medical gastroenterologists do this sit on tie? Could you please put up your hands? Most of them would refer to the surgical colleagues. So, what made you do this?
In the same token, it is the non-availability of surgeons, you started using it, or it is simple?
So, so 2-3 reasons. One is the first patient said she had already had 3 surgeries, including one recurrent ischiorectal abscess. So she said, is there anything other than surgery that you can do? I don't want to go back for another surgery. The reason why she needed to go back again and again for surgery was that, you know, again, biologicals, affording biologicals was a problem, and the treatment was suboptimal. I can't say that surgery was not the right thing. So that was the first patient. Then subsequently, we found it very useful during COVID. COVID was another reason. Actually, I didn't mention that. Surgeons would, the hospital policy, I can't say, they restricted all elective cases. So only the emergencies were being taken. So at that point in time also, we didn't stop doing endoscopies. So we continued doing endoscopies during COVID. So that was also another reason. Then after that, some patients, patients talk to each other, and then somebody said, why don't you try this? Like that. So it's still not our first choice, but it is an option that we find useful. Yeah, I know. Complex fistulas also, if there is no collection that needs drainage, you can still do it.
I know of some of the gastroenterologists in the US doing this sort of procedure, doing all sorts of things.
like putting in plugs, then putting in biologic substances, and fibrin glue. So quite a few of them, but very actively doing it, in the US. So, yes.
Sir, Dr. Venkatraman, when there is an established fistula, and sir has shown a fistula tract with 3 internal openings, without any draining inside the tract, that is, you are not doing any intralesional therapy, just putting a set on is not going to be beneficial. I introduced fistuloscopy in India. I was the first surgeon who brought fistuloscopy to India. So, in these patients with colitis, I do the intralesional treatment with the fistuloscopy, WAFT, and I do put a set on because in fistuloscopy we are not achieving an internal opening closure. Previously we thought of doing internal opening closure, but later we gave off. So, without doing any inside lesion treatment, that is inside the fistula treatment, just simple putting a set on and putting the patient on medical therapy is not going to be beneficial. At any point in time, they are going to have branches, they are going to have repeated collections, and when you start doing this kind of set-ons throughout that, the entire anus is totally scarred. Either they can go for incontinence of the stools, that adds to the misery to the patient. So any technology has to be scientifically based rather than just I know how to do it. This is my observation. And I have another question is the surveillance. Sir said surveillance of the patient you should take on remission of the patient. So whether we take it as a clinical remission to plan the surveillance, because many times we stop the patients who is not having a complaint, but when you do a surveillance scopy, we still see the active disease. So which is this remission? If it is a clinical remission or when you plan the surveillance? That is another question I want to ask.
Yeah, I think I'll answer first. The treatment for IBD is primarily control of inflammation. I think the fistula is a manifestation of poor disease control. The treatment of the tract, this is my understanding of the disease. The surgeon's perspective may be different. So whatever you do, I think if you don't get good medical control of the disease, then it's going to come back. So there are multiple techniques that are described on how to handle fistula, whether to cover it with a flap or plug or inject mesenchymal stem cells. But finally it boils down to that. So my aim is to make sure the patient does not have a discontinuation in immunosuppression. When do we have to discontinue immunosuppression? Is when a patient develops an abscess.
Majority of the fistula we see is also during an active flare where there's a lot of collection. Will US help? Is there any way US can help to drain these collections?
There are techniques described, but I have not done abscess drainage and then fistula at the same time. Usually they have spontaneous rupture or surgically treated and then they come back. I think Professor Vineet has got
congratulations, area, that was very nice. And so one question is that when there are deep ulcers or something in the rectum, and technically how much of EUS is feasible that time? Are you able to do, or that becomes a kind of relative contraindication because there's a lot of rectal inflammation out there?
EUS, you're asking. Yeah, no, it's not always that we do an endoanal ultrasound. Sometimes we just look at the openings and pass a wire. And a few patients we've failed. We've not been able to track the wire to the other side. Especially when there is like a small opening and there's a cavity. So the wire goes inside and just coils inside the cavity.
Dr. JJ, I appreciate your efforts taken for this. I think one of the most complex anatomy is the perianal fistula, complex. And I think we need to have a combined efforts of both physician and surgical gastroenterology. And everyone may not have that kind of orientation we have. I think youngsters should not go with the idea that complex perianal fistula can be managed comfortably for want of surgeon or thing. Our patient not willing, we have to educate the patient. In my humble opinion, I always depend on my surgical colleagues who would understand And what I've learned is they lay open the tract. That is also very, not simply placing a sit-on. I think we need to have a combined discussion before undertaking. And one of the most dreaded complication is the anal incontinence. And the other issue is when you are managing alone, the legal issues also.
Joseph, I saw you using a radial endoscope. Many of the centers don't have the luxury of having both the radial and linear. What about, have you tried linear endoscope in that? No.
I think on behalf of our colleagues here, Ubaldu and Balamurli, I should thank the organizers for giving this opportunity. I think we should move on to the next session. Thank you so much. Big round of applause to both the speakers and to Dr. Vandana who just left.
Thank you, speakers, and thank you, chairpersons, for the wonderful discussion. We'll move on to the next session, that is nutrition in IBD, a panel discussion. I would like to invite chairperson Dr. Padmanabhan, Dr. Ravi, Dr. Malarviri as chairpersons, and I would like to invite Dr. Paramanayagam from consultant gastroenterologist, Apollo Hospitals, to moderate this panel discussion. Just a small announcement, somebody has lost their car number of 8493. So if you want, you can collect it from the, yeah. So I'll hand it over to Paramanayagam for the panel discussion. Thank you.
Good afternoon to each and every one of you. At the outset, we thank the organizers for the opportunity given to us. Now, there is a panel discussion on dietary management of IBD. Moderator will be Dr. Paramanayagam, gastroenterologist from Apollo Hospital.
Good afternoon, sir. I'll call. Thank you, chairpersons, and good afternoon all. So move on to this panel discussion. I'll request my panelists. We have 6 panelists, eminent panelists from across Tamil Nadu. Request Dr. L. Venkatakrishnan, Head Department of Medical Gastroenterology, PSG, Coimbatore. Dr. Kandaswamy Layas Kumar, HOD of Medical Gastroenterology, Tirunelveli Medical College. Dr. Rajesh, Senior Consultant, Gokulam Hospital, Salem. Dr. Palnivel Mohan, Head Department of Medical Gastro, Jipmer, Puducherry. Dr. Arul, Department of Pediatrics, G and Hepatology, CMC. And Mrs. Jayalakshmi, a Senior Lecturer, Department of Dietetics at CMC, Vellore. So we have a very packed eminent faculty here, and so the next half an hour we'll be discussing about the role of diet and how it contributes to this IBD and what are the possible ways in which we can modify and modulate the diet in treatment of IBD also. So the outline will be on diet and its role in pathogenesis, the malnutrition in IBD, and the dietary management in IBD, looking at general dietary advice, specific diets, some adjuncts that can use, and at some point in role of parental nutrition also. So this was an interesting observational study where they looked at the patient's perspective, like what they thought, whether their dietary behavior contributed to their disease. So you look at it, about roughly about 80% felt that there was a role of diet in their disease relapse or in the remission. So that is a patient perspective, but is there a science behind it? That is what we are going to see and what we go about it. So the role, if you look at it, in the development of IBD, there is a lot of pathogenesis that has been described. It is maybe because of the type of diet that we use, the high carbohydrate, low fiber diet, the use of fast foods, the saturated fatty acids that come along. And these are some of the potential so-called factors that can contribute to the development of IBD. On the other hand, there are some protective factors also, in the form of dietary fibers, fruits, vitamins, which may protect against IBD. So there is a complex interaction that happens. And not only that, IBD also contributes to malnutrition. And there are multiple studies from India and other places where they show that the protein allergy malnutrition, the micronutrient deficiency happens pretty early in the phase of IBD. Even this study that showed that within a year, you will find that about 10 to 12% of patients who had a normal nutritional status become malnourished. And it is also, the micronutrient deficiency is also pretty common. When they measure, it is to the tune of 20 to 70%. So I'll start off with questions for the panelists. So Professor Venkatakrishnan, what do you think are the reasons for malnutrition in IBD?
I think the main reason for it should be noted the malnutrition starts very early in IBD, especially malnutrition is more commonly seen in Crohn's disease. I think the commonest thing is once you have an luminal inflammation, there is definitely a decreased food intake because of anorexia. Then recurrent small bowel obstructions, which could lead on to nausea and vomiting, can produce. And of course, once you have an obstruction or a luminal thing, you'll have a restricted diet. And some of the drugs which can use can also can produce, or anoxygenic can produce anorexia. And in Crohn's, there could be a nutrient malabsorption either due to a reduced absorptive service because of small bowel involvement. There could be SIBO, and we know that IBD is predominantly a protein-losing enteropathy, and that's one of the reasons why you can have malnutrition. Most of the times, anemia and iron deficiency could be due to a chronic blood loss, and that could produce iron deficiency anemia. When you have more than 30 centimeters of distal ileum is involved, then you could also develop steatorrhea and fat malabsorption. Generally, in Crohn's disease, there is an increase in resting expenditure, and that could produce malnutrition. And some of these drugs we choose can cause intense interactions, and they can cause anorexia, nausea, and nutrient malabsorption. These are the quite few reasons where you get malnutrition. It has been noted that malnutrition comes much early in disease, even before you get all these factors. That has to be noted.
Sure.
Vitamin D deficiency comes much earlier than it, but we do not know if you correct vitamin D, what is the on the course of vitamin D on the IBD.
Sure.
And second, as you said, the patient perspective, they themselves go on diet restricting mode, and it has been noted that in India at least more than 50% of people restrict themselves on a diet, and that could lead on to malnutrition.
Sure. So it's also important that we understand that we have to have a good nutritional assessment in IBD. We just have heard that the protein allergy, malnutrition, micronutrient deficiency all starts off pretty early in the stage of the disease. So I'll question to Dr. Arul, how do we screen for malnutrition in the OP, a busy OP setting or IP setting, and who would you refer for a detailed nutritional assessment?
Yeah, nutritional assessment in IBD involves basically two aspects. One is about screening, and another one is about assessment. The screening is mainly to look for at-risk patients. That should be applied for all the IBD patients to screen them for at-risk. And once we diagnose, once we get the feel of at-risk patients, then you have to go refer to the dietitians or the specialized unit for the nutritional assessment. So basically, nutritional screening involves detailed clinical history, examination. Anthropometric measures are important, but not exactly this one, other than anthropometric involvement also, like a BMI. Say BMI, maybe a normal BMI also, they may have sarcopenias, myopenias. So that's why the assessment is very important. That's why the nutritional screening tools, NSTs, has come. So there are various NSTs that has been universal screening, and IBD specific screening also is there. There are some of them I have listed, like MUST, NRS 2002, MST, all those things I'm not going into detail. And IBD specific are this SASC IBD, IBD NST. So among this one, SASC IBD seems to be more sensitive. So the other two tools, SGA and GLIMIS, for nutritional assessment. So these are all the assessment that can be done to diagnose the at-risk patients. So who are all the at-risk patients? Well, as Dr. Sir has already mentioned about those are an active disease, and those who are losing weight and low BMI, not only low BMI, normal BMI with visceral fat, saying that they may have sarcopenias also, those people, and who are waiting for surgeries and who are post-surgery, like a short bowel syndrome, those people also are at risk. And also all those patients who are scoring high in the screening test should be assessed for at risk. And specifically, I would like to give importance to the pediatric cases. Pediatrics are at risk, as Dr. Ramakrishnan sir and Maladi ma'am has specifically mentioned about the growth and development. So these children are at risk for malnutrition, and we have to screen them every time when we see them. And also psychological factors. And this is very important because that can lead to restriction of food and further malnutrition. I can share one experience where we have seen a young girl who has been followed up for ulcerative colitis, well-controlled disease, but she was losing weight on each visit. And finally, our dietetic team is able to get hold of the history that she is restricting the diet. So she went into she was a previously obese child who lost the weight, but she is happy about the weight loss and she wants to follow that. That's like a eating disorder she went into. So those type of things we can pick up from the nutritional screening. So answering to your question, all patients of IBD should undergo nutritional screening, and those who are at risk should be evaluated further for the assessment by a specialist.
Sure. And what do you do in a detailed nutritional assessment, Madam Jayashmi? So how do we go about proceeding with this?
So the first step is nutritional screening. Next to that is the nutritional assessment. So here I would like to talk about the direct method of the nutritional assessment, which is very simple and most effective. This is called the ABCD analysis. We dietitians usually practice this. So coming to A, anthropometric assessment, we quickly collect the height, weight, calculate the desirable body weight. So based on the desirable body weight and BMI, we fix the calories. If the patient is severely malnourished, we'll go for the high energy, that 35 to 40 kilocalories we can give per kg body weight. And coming to the biochemical parameters, we look for the relevant biochemical parameters. Say for example, we look for HbA1c. If it's high, then patient need to have a diabetic diet has to be followed along with high protein diet. And we also look for other parameters like lipids, creatinine values. Considering all these things, diet has to be modified. And one important biomark for the IBD patient is the albumin. If the albumin is very low, the patient has to really take a very high protein diet. With that high protein, good quality protein, we need to focus on that. Coming to the clinical methods, just clinically look at the nutritional symptoms. And coming to dietary evaluations, there are different methods are there. 24-hour recall method, food frequency. Out of that, diet history method is one of the easiest and most useful method what we follow for our patients. And this is our nutritional assessment screening form what we use in our hospital. So this has got 3 components. One is the BMI. So the score is given based on the BMI, and then unintentional weight loss, and then decreased intake of the food. So when you calculate all the scores, so we can know whether the patient is mildly risk or moderate risk or severely malnourished. And then we look at all the biochemical parameters, and then we'll collect the, can I have the next slides? So we mainly focus on the diet history method. So we ask the patient, before planning a diet, we'll ask the patient what is their usual intake, what is their eating pattern and their habit, the cultural, religious practices also we need to consider. And then the most important thing is the socio-economical status. So considering all these things, we need to plan a diet. Planning diet should be a personalized. And this is our standardized cups, tumblers and spoons. We use this and we ask the patient's intake before we plan the diet. So that this will give you an exact idea how much macronutrient, even a micronutrient consumption of the patient. So we'll show the standardized cups and we'll ask them how much quantity they consume, and then we converted into, this is all in the cooked volume. Then we converted into raw quantities, and with the help of IFCT, that is Indian Food Composition Table, which is given by ICMR NIN, we calculate the nutrient intake. And also we can go for this detailed PG-SGA, also can be used as an assessment. So this has got the first 4 questions can be answered by the patients. Can I have the next slide? And the rest of the questions has to be assessed by the dietitian. So this will give you the score like 0 to 1. The patient does not need So the score is given there, 0 to 1 and 1 to 2. So based on the scoring, the patient has to be referred to the diet consultations.
Do we have any specific diet that can be recommended in all IBD patients as a general rule? Suppose they are on remission, not in specific active disease. Is there a specific dietary recommendation that has come through?
According to AGA clinical practice update on diet, actually one thing should be driven home is that no diet has consistently been found to decrease the flares in adult IBD. Unless there is a specific contraindication, all the patient with IBD should be advised to follow the standard Mediterranean diet. And actually the short-term use of reduced fiber and low fermentable oligosaccharide, disaccharide and polyol dietary approach during the symptomatic IBD flare may be helpful. But when the patient has achieved the symptom resolution, they should be advised to follow the regular Mediterranean diet. Actually, the description of a Mediterranean diet is a high intake of vegetables, fruits, cereals and legumes, nuts and unsaturated fat like olive oil, and moderate intake of fish and dairy products and wine, and low intake of saturated fat, meat and sweets. Actually, you have to fill up the stomach with a lot of vegetables and allow less space for other meat and other things, and that is the recommendation. And another study has shown that the dietary fiber intake and risk of IBD has shown that the linear dose-response relationship was found between dietary fiber intake and Crohn's disease risk development, and the risk of the Crohn's disease has decreased by 13% for every 10 gram per day increment of fiber intake. And the result from this meta-analysis has shown that the intake of dietary fibers are significantly associated with reduced risk of IBD. And another study has shown that there is the reverse, the odds ratios have shown that the inverse association between the intake of vegetables and the risk of ulcerative colitis, and intake of fruits and risk of ulcerative colitis, and the intake of fruit and the risk of development of Crohn's disease.
Sure, sir. So moving on to this is micronutrient deficiency. We did see that it is pretty common and seems to happen pretty early in the course of the disease. So how do we manage, what do you look for, and how should be treated? Dr. Palni.
As Dr. LVK had told in his discussion, that patients with IBD are at risk of micronutrient deficiency for several reasons. Because of inflammation, there is anorexia. There can be, patients may resort to restrictive food type. They also undergo a lot of surgeries, especially in Crohn's disease, and there are drugs that can interfere with absorption of some of the micronutrients. So there are certain important things, like when one is evaluating a patient for micronutrient deficiency, is when you interpret the blood results, these interpretation has to be done with caution, because many of these micronutrients are either positive or negative acute phase reactants. For example, ferritin and copper increase in the presence of inflammation, whereas on the other side, on the other hand, folate, selenium and zinc decrease with inflammation. So micronutrient deficiency commonly, micronutrient deficiency can result in anemia. It can impair the linear growth and cause poor bone health in patients with IBD. So there's a need for routine monitoring to screen for deficiency. So in the routine screening, usually one checks for evaluation of anemia and vitamin D, calcium status. Anemia, as you know, is the most common extraintestinal manifestation in a person with IBD. Anemia can be because of bleeding, blood loss, or can be because of iron deficiency, folate or B12 deficiency. And one should always remember anemia of chronic inflammation when confronted in an IBD patient with anemia. So diagnosis of iron deficiency is made when ferritin levels, normally in the absence of inflammation, somebody has a quiescent disease, if it is less than 30 micrograms per liter, But in the presence of an active disease or a biochemical evidence of inflammation, a value less than 100 micrograms can be considered as iron deficiency. And all patients with proven iron deficiency need supplementation. Oral iron is preferred in patients with mild anemia or a clinically quiescent disease, whereas a person who has a severe disease, an active IBD, severe anemia, or intolerant to oral iron need a parenteral iron. And there's a simple scheme for estimation of total iron need estimation. In people with severe anemia, depending upon the body weight, they may need anywhere from 1500 to 2000 milligram. Whereas those with mild anemia will need anywhere up to 1000 to 1500 milligrams. Another important thing that one looks for is bone and health status in that vitamin D levels, 25-hydroxy vitamin D level measurement. Any patient with less than 10 has a deficiency, whereas between 10 to 20 has insufficiency. And dietary counseling is required. Say anybody who has bone mineral density defect, it can be because of nutritional deficiency, per se because of chronic inflammation they can have bone mineral health can be affected, or because of a chronic steroid or a long-term steroid exposure can also affect the bone mineral density. So patients need a close monitoring, like those who have an active disease, monitoring needs to be more frequent, once in 3 to 6 months. And also previously stressed by panelists that vitamin D has got an immune modulation role, so adjunctive therapy has been tried in patients with IBD. So important thing also, proactive screening for osteopenia or osteoporosis is required, and supplementation or replenishing stores are done as the results come by. The other micronutrients are one looks for is B12 and folate. They can cause macrocytic anemia. Anybody who has severe disease involving the terminal ileum more than 30 centimeters or who undergoes resection. And there are also, as alluded, certain drugs can interfere with folate absorption like sulfasalazine and methotrexate. B12 deficiency is diagnosed when its serum value is less than 200 picograms per ml. And RBC for folate, RBC folate or serum folate can be measured. Any value less than 2 nanograms means that they are deficient. When there is a doubt, measurement of methyl malonic acid or homocysteine levels can also help in ascertaining whether there is true deficiency. And supplementation of 1 milligram of folate every day replenish the stores within 2 to 3 weeks.
So, Dr. Rajesh, I mean, there are so many misconceptions from the patients when they come to you in the OP. So, is there specific food which should be restricted? I mean, what do you suggest?
So, as Kandasamy mentioned, the fiber is a protective in IBD because it favorably alters gut microbiota. But a lot of things, misconception in food things, especially if a patient in acute flare, better to reduce the high fiber diet because it may produce bulky stools and produce pain. It's better to avoid a high fiber diet like whole grains, fruits, peels, and raw vegetables, better to avoid. But once the patient goes for remission, then you can gradually add the soluble fibers. Coming to the recommendation of gluten, there is no need to restrict the gluten. It is not a gluten-sensitive enteropathy like a celiac disease. It is so there you can give a routine. There is no need to restrict the glutens. Coming to the milk and lactose intolerance, actually, if at all, if an acute diarrhea, severe disease, it is secondary lactose intolerance. It is not a lactose intolerance. And as previous speakers mentioned, it is a malnutrition. So you should not reduce the lactose milk in IBD as such. But during the acute flare, you can reduce the quantity. Then gradually we can add the lactose diets. A low FODMAP diet in IBD. So we all know the IBS and IBD coexist most of the patients. When compared to the IBS in general population, in IBD, IBS is more common in IBD patients. So probably the IBS component, the low FODMAP diet helps in IBS subgroup of patients.
Okay. So now moving on to from general recommendation, there are specific diet patterns, I mean, which has been used as a therapeutic agent in IBD, and we'll be discussing in the next 10-15 minutes regarding this. But before we go on, what are the different types and what is the rationale for the specific diets that have been tried as a treatment-specific modality in IBD?
Nutrition as a therapeutic armamentarium in the initial phase of IBD has now been evolved. So either it ranges from elimination diet or modifying the diet. And it has been shown that if you can bring down the emulsifiers in the regular diet, it reduces the gut inflammation and dysbiosis. Occasionally when there's too much of a low FODMAP diet brings down the abdominal distension. And if you have an exclusive enteral nutrition which is used in active Crohn's in children, as well as known to bring down the pro-inflammatory cytokines and regulate the immune system and decrease the mucosal permeability, increase the gut barrier. Then there is this Crohn's disease exclusion diet which could bring down the American College of Gastroenterology, but has not really been seen in the ECHO guidelines. So these are some of the diets which have been as a rationale of bringing down predominantly the inflammation, bringing down the mucosal regulation of the immune system and decreasing the mucosal permeability.
To Mrs. Jayalakshmi, what is this exclusive enteral nutrition and the Crohn's disease specific diet? Like, what does it contain? Is it possible in Indian type of food intake that we do?
So this exclusive enteral nutrition is a form of intense diet therapy, which is usually recommended for the children with the CD, expecting 60 to 80% of remedies to follow 6 to 8 weeks of period. So they are allowed to take commercially available formulas, either it can be a polymeric, can I have the next slide? Polymeric formulas or elemental or semi-elemental formulas which is available. Compared to polymeric, these elemental and semi-elemental formulas are very costly, which most of the patients cannot afford. So polymeric formulas, similar to that, we can try preparing at home. But we haven't yet tried. I think we need more research on that compared to commercial formulas and then home-based formulas. Can I have the next slide? So CDED diet, it is a combination of whole diet plus partial enteral nutrition. It contains a high protein, low fat, low animal fat, less gluten, and then additives free, which also has got some amount of fiber in it. Fiber like pectin and resistant starch will really help, which we get from fruits and vegetables. It reduces the C-reactive proteins, and obviously remission is happening and reduces the inflammations. Since this diet has got some amount of fiber, which is fermented by the gut microbes and produces butyrate, it is one of the short chain fatty acid which helps for the restoration of colonic epithelial integrity. Can I have the next slide? So in CDED diet, there are 3 phases. Week 1, 50% of partial enteral nutrition can be tried. This partial enteral nutrition can be a commercial formulas, or we can go for a home-based formulas also, there are possibilities. And in week 2, that is phase 2, 75% of diet and 25% should be 75 to 100% of diet, and PEN can be optional. Whereas in the maintenance phase, that is after 24 weeks. So we need to consider these points. So the diet should be tailored. Can I have the previous slide? So the diet should be personalized, and then we can ask the patient to maintain a food diary where they could find out the triggerer foods. We can ask them to note it down once when they take any particular food, if they develop any symptoms, ask them to note it down in the diary and stop it for 1 or 2 weeks. Then later they can try out and see whether again it triggers the symptoms. And for the children, we have to monitor the growth. Can I have the next slide, sir? So in phase 1, what are the foods to be avoided? Like foods which is rich in fat, omega-6 fatty acids, saturated fats, red meats, processed foods, ultra-processed foods, emulsifier, additives, alcohol to be avoided for all 3 phases. Emulsifier, additives, alcohol to be avoided for all 3 phases. Whereas in the phase 1, foods like rice, fish, chicken, the form of, the consistency can be changed. Like it can be a soft, minced fish chicken and vegetables and fruits like banana, apple, which contains a pectin, can be introduced. Whereas in the second phase, we can increase slowly the quantities of vegetables and fruits, and some more varieties of vegetables and fruits can be included.
Standard.
So these are some of the standard formulas what we suggest for our patients in our hospital. It's kitchen-based formulas which is made out of rice flour and a little bit of milk. If they are not allergic to milk, not allergic to lactose, then we can go for a milk. And then we are using Ensure Plus. It's one of the scientific formulas. This is just to get the micronutrients. If patient cannot afford, then we can go for cooked dal or the roasted dal powder or nuts powder also we can advise. We have advised the patients, and patients also afford to use, and we have got a good feedback from the patients also. And the another formula is the lactose-free formulas. Here we are not used any milk. Maybe we can use curd here, again with the rice flour and commercial formulas we have added, and little bit of oil. So this gives around 500 calories and 20 grams of protein.
Must have been much more versed with this exclusive enteral diet and nutrition. So how effective is this in practice?
So as far as like all the diets have been mentioned, but particularly EEN is more effective. Not only in children, but adults, it's not routinely used. So as far as children are concerned, is first line, recommended as a first line therapy for those with mild to moderate active disease. And it's proved to be, there is a strong guidelines, all recommend EEN. And it's proved to be more effective in inducing remission and inducing in mucosal healing, and also in bringing down the inflammatory markers. So EN is very effective in children, and it's equivalent to steroid.
How has it been in your experience? Like, is it practically feasible?
So in our experience, again, this one problem of adherence is a major problem in pediatrics as well. Even can overcome that. But it's because of the compliance problem, sometimes we have to stop the EN and start steroids. But in adults, it may be equally effective, but it's variable and it's not routinely recommended, and adherence is the main problem. And that is EN is proven. And coming to this CDED plus partial enteral, as Jayalakshmi was talking about the CDED and PEN, it's also, there is some evidence that this is also effective, particularly when it's combined with both parenteral nutrition as well as the partial enteral nutrition as well as the CDED. So this, the bar diagrams are showing study from the Levine, where he compared the EN with CDED plus PEN. So what he's showing is tolerance is good in CDED, but however other parameters like remission and maintenance of remission, all those things are equal in both of this one, and both are effective in bringing down the inflammatory markers also. So that is about the CDED. This table shows the various effects of the other diets as well. So we talked about EN and CDED, and Mediterranean diet, as sir has rightly mentioned, it's like for the general health. It's a good diet with vegetables, nuts, and less carbs and more protein. So it's generally recommended. And food map is particularly symptomatic relief for IBS. It will be useful. And carbohydrate diet, specific carbohydrate diet, there are a lot more studies needed to prove that this is effective. So answering to your question, how effective are these specific and adjuvant therapies rather than as a whole, it cannot replace the medical management. And also there are a lot of interest in developing new diets, and but however there is no specific recommendation so far to implement them in the clinical practice, except exclusive enteral nutrition, which has been proved in pediatrics.
Sure.
Thank you.
Thank you. So diet as an adjunct to treatment, coming to that, I mean, what is the role of curcumin? Has been recent interest about curcumin, coconut water. So what, or Dr. Palni?
First talk about coconut water. Coconut water has been shown to have an anti-inflammatory effect, as well as has a role on modulation of gut microbiota. Dr. Benitza's group had published this study a couple of years ago. Coconut water as an adjunct therapy in mild to moderate ulcerative colitis. In addition to standard medical therapy, one group was given 400 ml of coconut water for 8 weeks, included in modified intention to treat analysis. And the primary objective as clinical remission was statistically significantly better in the group which received the coconut water. And similarly, the clinical response also was better. And they also, as a part of secondary objective, looked at the microbiota composition at baseline at 8 weeks. And the bacterial taxa abundance, specifically with significant negative correlation to clinical indices, biochemical and endoscopic indices of severity, was increased actually. So the authors concluded that coconut water is more effective than placebo for induction of clinical remission in patients with mild to moderate ulcerative colitis. And nutraceutical agents are foods that provide medicinal or health benefits. They are not only used for treatment of disease, but also for prevention of disease. And over the last 10 to 20 years, more focus has been on polyphenols. And curcumin is a naturally occurring polyphenol obtained from the rhizome of Curcuma longa. The multiple benefits are anti-inflammatory, antioxidative, and also has a role on intestinal microbiota. We recently published an umbrella review looking at assessing the strength of evidence for curcumin in UC. 7 systematic reviews and meta-analysis were studied, and 18 outcomes, out of the 18 outcomes, none of them were supported by a high certainty evidence. So curcumin has an uncertain therapeutic potential in UC.
Dr. Rajesh, I mean, from Chennai, I think from Tamil Nadu, there's a lot of interest now, becomes almost like a fad that most of the people are going back to using some fermented rice. So is there a role as a treatment?
Yeah, fermented rice or palaya kanji or palaya sadam, what we call in Tamil, and it is rice soaked in water. For a lot of myths and hypes about this rice, fermented rice. Biologically, it is a rational, there is a lot of rationale for using this because it favorably alters the gut microbiota, and it improves the short chain fatty acid and butyrates, which are the nutrients for the colonocyte. And scientifically it is a useful one, but can we extrapolate this into clinical effectiveness? That is a question. And only few studies, especially from Tamil Nadu, Chennai, they say that it is very useful in IBD. But as an adjunct, it is not a primary modality as mentioned in the previous speakers. And there is no randomized control large studies available, and the guidelines also don't recommend this as a primary modality. Having said this, we can in the case of IBD or during the remission, not in an acute phase.
Sure. Is there a role, I mean, we have full nutrition, but is there a need for parental nutrition? And if so, what are the indications?
Yes, sir, definitely there is a role of parenteral nutrition in IBD. When the enteral nutrition is failed and there is a preoperative conditions where malnourished and unable to take oral intake, you have to either use enteral nutrition, that is a liquid formula, and or parenteral nutrition before proceeding on to the surgery. And other instances where the abscess development in Crohn's disease, you have to put the patient on nilparental oral, and then you have to give the parenteral nutrition therapy before going on to surgery. In other cases like high output fistulae and prolonged ileus and short bowel syndrome and severe malnutrition and inability to tolerate oral diet and enteral nutrition, then we have to proceed on to parenteral nutrition. In another instance where there is short bowel syndrome in addition to IBD, also we have to give parenteral nutrition in the form of IV fluids and other nutrient therapy.
Thank you, sir. I think with that we complete the panel discussion. It's open to the hall for discussions.
Thank you, Prema. Before opening up, I want to ask a question to Dr. Vineet. We talk so much about genes. Genes are there. When we call genes, it is in the germline. And germline changes happen many thousands of years. What has changed in the last hundreds of years is industrial scale of production of food by using fertilizers and synthetic manures. Do you think these changes in the way we produce food and convert food into product cause the genes to behave the way they behave to cause IBD?
So the genes won't change, but the epigenetics can change. So that's exactly what is happening. The environmental factors, the dietary factors, possibly they're causing epigenetic changes. And that is why you're seeing the epidemiology of disease which is changing. For the gene to change, maybe in celiac, the kind of wheat which has been used there, the wheat gene may have changed so as to make it a kind of autoimmune trigger. But for IBD, it is the epigenetics here which would be changed within a generation because of environmental, dietary, extraneous factors, which can include things like refrigeration, which can include things like toothpaste, which can include things like ultra-processed food, anything out there. Or even microplastics can be one of the possible causes.
So how much do you advise organic food for managing IBD?
Again, the answer is not that simple. A simple example is, we say vegetarian food is good, non-vegetarian food is not good, plant-based diet is good in terms of decreasing inflammation. If you go to Manipur, you will not find so much of IBD. If you go to Arunachal, you will not find so much of IBD. There they eat only non-vegetarian food. In Ladakh, they keep stored food for 6 months, eat non-vegetarian food, they don't find IBD. So it is not as simple as a linear factor like this. It's a combination of factors which leads to a change of extraneous point. Yes, if you say that what should I do so that I really don't develop it, then obviously you relocate to a poor country, let us say somewhere in Africa. If you go there, then the chances would. When you relocate to a rich country, like Dr. Jayanti's studies, they showed that when you relocated to UK, people who were not developing IBD earlier out here, they were developing IBD out there. So if there's a reverse migration, that might be able to change the epidemic.
You had a lot of experience with curcumin. Where do you place it?
Curcumin is good. The curcumin major problem is bioavailability. So when we did the trial, we were very hesitant in increasing the dose over 1 gram or so, 700 calories or less, and 7 days a month for 3 months. So these patients, when they were put on a low-calorie diet, kind of semi-fasting state, they did better in terms of achieving much higher clinical remission.
Next session.
Thank you. We'll move on to the next session, which is the last and final session, IBD special situations. We've already had one talk. The second talk, which is optimizing management of Crohn's disease before surgery. I'd first like to call upon the chairpersons for the session, Dr. A. Ratnaswamy, Dr. A. Murali, Dr. M. Hariharan, and Dr. B. Sumati. I would like the chairpersons to please introduce the speaker, Dr. Alagam Maiman.
I think we are coming to the last session of today's proceedings, IBD in special situations. The senior consultant in Meenakshi Mission Hospital, Madurai.
Good afternoon all.
Over to Dr. Alagam.
Just away from our lunch plate, so I'll make it short. So this is about preoperative optimization in Crohn's disease. So even in this contemporary era of so many biologic cells and so many small molecules, still many of our patients, even up to 50% of patients with Crohn's disease will land up in some form of surgery in their lifetime. So, and these surgeries are associated with comparison to other routine bowel surgeries. So the commonest indication would be to go for a fibrostenotic stricture, or it may be a internal fistula landing up in abscesses. So to note, most of the time these surgeries can be made elective rather than emergent. Emergency surgery will be needed only in certain small number of peritonitis or a massive hemorrhage, which are actually rare in Crohn's disease. So most of the patients can be planned for an elective surgery rather than an emergency surgery. Because the surgery is always associated with a lot of complications, particularly anastomotic leak, abscess, sepsis, and also non-surgical site infections like pneumonia. And we should also remember that these people are more prone for DVT. So there are some modifiable factors, there are some non-modifiable factors. We are much interested about the modifiable factors because we can modify them so that we reduce the post-operative or the perioperative complications. So the most important modifiable factors are malnutrition, much is discussed about nutrition just now. And then the steroid use, whether the patient is on steroids at the time of surgery. And third is control of intra-abdominal sepsis. And fourth is cessation of smoking. So these four are the most important modifiable factors in controlling the post-operative complications. So we'll start our discussion with the patient. Here is a 24-year-old male, known case of Crohn's disease, at diagnosis A2L1B1. And he completed steroid induction and he was on azathioprine maintenance and he was in good remission for close to 2 years, compliant on azathioprine. Only along with infliximab because he's biologic naive. Somebody may opt for cut now, go for right hemicolectomy, drain the abscess and then post-operatively put the patient on infliximab prophylaxis. Somebody may go for wait and cut where we will wait with antibiotics, percutaneous drainage and then plan for infliximab and operate only if it is needed. So these three are the options in front of us. So whether we have to go for an emergency surgery or an elective surgery, it has to be decided. So here in this patient, it would be ideal to go for a wait and cut rather than cut now. Why? See the data. So this is a meta-analysis of 75,971 Crohn's disease patients across 15 countries who have undergone bowel surgeries, not the perineal surgery. Discussion is on bowel surgery. So many 75,000 patients who have undergone bowel surgery, if you see, the mortality is 6-fold higher if the surgery was emergent. So 0.6% mortality in an optimized patient where the controlled inflammation, optimized nutrition, multidisciplinary planning, this patient has a mortality of 0.6%. If the same patient is taken up for an emergency surgery where there is an uncontrolled inflammation, low albumin, patient is malnourished, anemic, this patient, and patient is on steroids, our patient is on steroids for the past 8 weeks. So this patient, if we take up for direct surgery, then the mortality is expected to be higher as shown here. It is 0.6% versus 3.6%. So for our patient, it would be good to go for the third option, which will be wait and cut. So the echo also says the same thing. If you see the statement 4.1, we recommend elective bowel resection over emergency surgery in patients with Crohn's disease. And they say preoperative optimization should be initiated, followed by reassessment of the patient for surgical intervention. So always it is optimization. So we know that we have to optimize our patient before operating. So what are the domains where we can go for preoperative optimization? One is control of sepsis. Our patient has a psoas abscess sitting there, 3.5 centimeter. Second is taper steroids, because using steroids at the time of surgery is obviously going to be associated with poor wound healing and higher chance of anastomotic leak. Third is improving nutrition. So these three are the major domains where we have to optimize the patient before operating. So domain 1 is malnutrition. 20 to 85% of Crohn's disease patients are malnourished. Very nice talk was given about the MUST tool, the screening tool for assessing malnutrition. And every patient with Crohn's disease should be assessed, should be screened for presence of malnutrition and should be getting education regarding proper nutrition only in the preoperative period. It's due to various reasons that they are all malnourished, like reduced intake, nutritional loss, disease-related catabolism, steroid use leading to lean body mass. They will all look obese, but they will be sarcopenic. So lean mass will be lost due to steroids. So malnutrition at the time of surgery equals to very high post-operative complications. It's understood that low albumin doesn't mean malnutrition, because low albumin also reflects the high inflammatory burden. So see, our patient has low albumin, anemia, and he's already on steroids for the past 8 weeks. So he is a high-risk patient. So we have to improve the nutrition before sending the patient for surgery. So this is the meta-analysis from 2018, where they have shown 1,111 patients across 5 studies. If the patient was preoperatively optimized with the proper nutrition, programmed nutritional optimization, then the post-operative complication was much less, 20% versus 61%, which is much true with enteral nutrition, 21.9 versus 73.2%. So number needed to treat to avoid one post-operative complication is just 2. So if you treat 2 patients with proper nutrition prior to surgery, you're going to avoid one post-operative complication. So conclusion is preoperative nutrition markedly reduces post-operative complications. So our patient is malnourished, so we should not directly operate this patient. We have to plan for optimization where we are going to involve a good dietitian like Mrs. Jayalakshmi. So these are the options that discussed now. Options to improve nutrition. This we are particularly discussing the preoperative situation, where even in adults we can consider exclusive enteral nutrition. Exclusive enteral nutrition, I guess postgraduates are also there. Exclusive enteral nutrition is one where we are not able to allow, we are not allowed to take even milk. We have to take only formula feed. If it is Ensure Plus, for the entire day it is only Ensure Plus. If it is Peptamen, it is entire day Peptamen. Nothing. Maybe black coffee is allowed, maybe water alone is allowed, nothing else is allowed. So such a difficult, less palatable, adherence issues are always there. But if we give exclusive enteral nutrition in the pre-operative period, have shown that even minimum of 2 weeks have shown a very good improvement in disease activity, improvement in albumin, reduction post-operative complications. Particularly studies that focused on EN in the pre-operative optimization, it has got a very wonderful role. Probably it is possible. 2 weeks may not be difficult even in adults, I guess. If it is difficult because of adherence issues and palatability, we can go for partial enteral nutrition that they showed very nicely. So 50% is formula feeds and 50% is where you avoid all this. Basically, packet of riches, that's CDED, Crohn's disease exclusion diet. Third is TPN. So sir was telling very good about TPN, that only for very selected patients. Somebody who cannot tolerate enteral, then only we have to go for TPN, just because we want to increase the albumin before surgery. You want to push the patient for surgery some 3-4 days and you want to give TPN for 3-4 days. That's not correct. So TPN has got its own problem like catheter risk and cost. And in studies that have compared enteral versus parenteral nutrition prior to surgery, TPN actually had a worse outcome with regard to post-operative PN. So our target 1 is nutritional optimization, 2 to EN or a PN, and it's got a high impact on post-op outcome, and we have to concentrate on micronutrient deficiency also, as Dr. Palnivel was speaking about. So our patient is on steroid. For the past 8 weeks, he's on steroids. So steroids are double-edged swords in IBD management. They are sick patients. They are all requiring surgery. They are sick and they are often steroid dependent, or they are already on reinduction or steroid therapy for a flare like our patients. So they're all at risk in the post-operative period. So we have to come down on steroids before sending the patient for surgery. So what's the role of steroid use? Meta-analysis way back, 2008 meta-analysis of 12 studies, 3,807 patients who were on steroids at the time of surgery. For this 3,000 plus patients, if we see the overall complications for patients who were on steroids, which much higher with an odds of 1.4, particularly infective complications. The higher the dose, higher the risk. So what they found, that if the patient was on more than 40 mg per day, then the odds of developing some form of major not the minor one, major post-operative complication was 2. So conclusion is pre-op steroids, it will if it is dose dependent or the duration also. So better to come down on steroids. So for our patients, we have to, for our discussing patient, we have to come down on steroid, taper the steroid, and then only we have to send the patient for surgery. What about biologic and small molecules? Biologicals are safe. This is this confirmation is with the Puccini trial, which is the largest prospective trial on patients who were subjected to surgery while they were on biologics. Many of these patients had a drug trough level tested just before surgery, and they followed the patient post-operatively to find out whether they develop complications. And they found out that biologicals are safe even among patients who had a detectable drug level at the time of surgery. There was no higher risk of developing post-operative complications. Better to schedule the surgery in the mid or late time of the dosing. For example, if the patient is on infliximab once in 8 weeks, by 4th or 5th week, we can plan for surgery. And then go for the next schedule after the 3 more weeks of surgery. So continue post-op as per the schedule. This confirmation is from the Puccini trial. How also associated with higher risk of DVT, and in the perioperative period, we should ensure that we are giving thromboembolism prophylaxis. And theoretically, in the perioperative period, DVT may increase, so we have to stop the drug 3 days prior to surgery and restart once the patient is on oral. So target 2 is pharmacological optimization. So more than 20 mg prednisolone per day for more than 6 weeks is a strong predictor of post-operative infective complication. So better to taper and stop steroids at least 1 week before surgery. Threshold of less than 10 mg is always preferred. If at all if you are not able to stop steroids, threshold of less than 10 mg should be achieved, which is associated with lesser infective complication. But however, if the patient is on steroids at the time of surgery, better not to do the anastomosis. Go for stoma in order to avoid anastomotic leak and sepsis abscess. Immunomodulators are safe. If the patient is on azathioprine, we can restart azathioprine or we can continue during surgery. So target 3 alone I will finish. Domain 3 is intra-abdominal septic complication. Our patient has a psoas abscess. Such sort of intra-abdominal septic complications are very common. 10 to 30% of patients with Crohn's disease will have intra-abdominal septic complication in their lifetime. Pre-operative control of sepsis is always leading to better post-operative outcome. Presence of abscess predicts higher chance of stoma, higher chance of leak, and recurrence of abscess in the post. You do surgery for abscess and you will end up in one more abscess. So what is the role of percutaneous drainage of abscess? Here is a 2015 meta-analysis of 513 patients across 9 studies, and all these patients had abscess, and those who underwent bridge therapy with preoperative percutaneous drainage followed by surgery had a significant reduction in complication with odds ratio of 0.44. The postoperative recurrence of abscess was no different between patients who were directly taken up for surgery versus who was taken up for a percutaneous drainage bridge followed by surgery. So our patient has a reasonably bigger abscess, more than 3 centimeter. We can go for a preoperative drainage and then take the stoma nurses, psychology counseling, everything we should do, and then send the patient for surgery. Thank you.
Thank you very much. That was a wonderful overview into pre-operative optimization in patients. Sir, do you want to ask any questions? A couple of questions because we are running short of time. Any questions from the audience?
You were talking about avoiding an emergency surgery when there is an abscess or a thing. But we had a patient who was a young lady diagnosed in 2017, went into Siddha medication, now came with a very persistent severe stricture and a partially dilated abdomen with severe sepsis. And in this situation, there was no collections. And she came and even arrested in the emergency, revived. And even though we tried to do some conservative management, the counts went up to 54,000 and we had to operate as an emergency. So what do you think on these situations? Because the obstruction was just not getting relieved. Sepsis was being relieved. There was no other source of sepsis except we thought it was a persistent obstruction and a translocation.
Yes. Certain situations, it's all individualized, but better whenever possible, like the patient that I showed, everybody's intention will be to go for right inequality where we can optimize. But certain situations like a frank perforation, peritonitis, or such a patient who is in complete obstruction where we can't wait for surgery, we have to go. Where we can do a stoma, and such situations we can optimize with the proper antibiotic cover, 2-3 days of TPN, and then we can take the patient for surgery.
No more questions. Thank you. Thank you, Dr. Very good presentation.
Thank you. Thank you.
Thank you for the opportunity.
Thank you, chairpersons. It's a wonderful discussion. So we have come to the end of the session. So we had a very good academic feast today. So I would like to take this opportunity to thank the participants who has come from Chennai and from outside of Chennai to make this successful event. I would like to thank the faculty members, the chairpersons, the speakers, and especially to the CCF National Office Bearers, Dr. Ajay Kumar, Dr. Vinit Ahuja, Dr. Vandana, and the organizing committee headed by Professor Dr. K.R. Palaniswamy, Dr. Paramanayagam, Dr. Amit, and all the TN chapter CCFI governing body members and TNSG office bearers, Dr. Karthik, for making this event very successful. We'd like to thank Tamil Nadu Gastroenterology Trust for the financial support, and Sun Pharma particularly, and Residency Towers for providing this ambience and the place for this successful event. And I would like everyone to join for lunch, which is specially prepared for you. Enjoy the lunch. And yeah, I would like to thank the audiovisual people for providing this help to us. So we'll catch up with the next event. So you'll be receiving the e-certificate on email who have attended this conference. So we'll catch up with the next CCFI meeting. We'll be informing you through WhatsApp. Thank you, everyone. Thank you.